You must have gotten onto it first.
Okay.
It happens. Thank you so much for being so flexible and patient. So welcome to the Health and Government Operations Committee. Please do not forward the Zoom link for the hearings. Staff will not allow anyone who was not invited to testify to the hearing. I ask you to encourage people to watch the hearing on the YouTube channel. Bill sponsor witness timing. The bill sponsor or a designee is allotted 5 minutes to present the bill. 5 witnesses will each be allowed to speak for the 2 minutes in support. Please hearing until the delegates have had an opportunity to ask questions. Next, 5 witnesses will each be allowed to speak for 2 minutes in opposition and then respond to questions. Please conclude your remarks when you hear the timer ring. Melissa will let you know. Members must remain present with video camera on during the entirety of the hearing. It is a rule. Members, please ask only one question of one witness. If you have other questions, you may follow up offline. Please use the raised hand function to indicate that you have a question under the participants icon. We have 10 bills today on the agenda. In the event that we're not done by 3:15, we will then take a break and reconvene at 3:45 and continue with the rest of the hearings. So I have today the following bills. We have first House Bill 737, and that's the Speaker, Administration, Emergency Services, Exposure to Contagious Diseases and Viruses, Notification and Other Requirements. House Bill 737. Who will speak on this bill?
I will, Madam Vice Chair.
Actually, good afternoon. How are you?
Good. How are you?
Good. Welcome to our committee. Will you be so kind and get started?
Absolutely.
Thank you.
My name is Jake Whitaker. I'm with the Governor's Legislative Office here to testify in support of House Bill 737. This bill is part of Governor Hogan's commitment to enhancing the safety and well-being of first responders, especially during our pandemic response efforts. House Bill 737 will help protect first responders and frontline workers, including firefighters, police, and emergency medical services personnel, by requiring medical facilities to notify them upon possible exposure to COVID-19. So the way that would work, for example, is with an EMS personnel, they would transport a patient to a hospital. The hospital would confirm that that person is COVID positive, and then the hospital would be required to notify the EMS facility that that person may or may not have been exposed to COVID-19. What the bill also does is it allows medical facilities to notify the different EMS facilities or police departments or fire stations through the CRIPS system. So they can do that a little more quickly and efficiently. This bill is pretty straightforward. It basically adds COVID-19 to the list of diseases in health general where this notification requirement is required. It adds to the list of diseases like HIV, rabies, and tuberculosis. What this bill will do is codify existing emergency orders. So we think it's pretty straightforward. It's already happened and it's already helped keep first responders safe. We believe, though, that a significant degree of risk will still remain for first responders even after the state of emergency has ended. So we think that this is important to codify this requirement. And so for the aforementioned reasons, we respectfully request a favorable report on House Bill 737. And if okay with you, Madam Vice Chair, I'd like to turn it over to Dr. Ted Delbridge.
Absolutely.
Great, thank you.
Hi, good afternoon. Thanks for this opportunity. I'm the Executive Director for the Maryland Institute for Emergency Medical Services Systems, and just by way of a reminder, we exercise our responsibility to coordinate and oversee the EMS system through licensure and certification of EMS clinicians, EMPs, and paramedics in the field, and designation of EMS operational programs, or those agencies authorized to deliver EMS in Maryland, amongst several other things. Section 18.213 of the health article, which this bill seeks to amend, is incredibly important to first-line responders. It ensures they are alerted when they may have been exposed to a communicable disease. It provides an opportunity for risk assessment, and it provides an opportunity to implement prophylactic measures as may be appropriate for the specific circumstances. In the case of the virus that causes COVID-19, this represents unique risks based on its mode of transmission and potential for spread. Knowledge of potential exposure allows EMS personnel to assess their own personal risk, as well as an occupational health approach to assessing risks within the workplace and among coworkers. This has been incredibly important over the course of the past several months, where emergency services providers have taken exceptional measures to ensure their ability to respond to the next emergency call. By way of practical innovation and motivated by the pandemic, and also made possible by the statewide Health Information Exchange, or CRISP, and the statewide EMS medical record, we've been able to link every positive COVID-19 case with available EMS and public safety records. And this enables notification of EMS agencies when there's a linked match. So a patient in the hospital is diagnosed with COVID-19 and there's a linked match to an EMS record, and CRISP can facilitate notification of the appropriate public safety entity. So the authorization to use information that way currently exists in executive order. It'll go away when the executive order expires, but we perceive that the need will not go away. And for that reason, we ask that you help codify what currently exists. Thanks for your indulgence, and MEMS respectfully request a favorable report for House Bill 737. Thanks.
Our pleasure. Thank you for being with us today. Next, actually, this will be the panel, the favorable panel, and it concludes right here. Are there any questions for this favorable panel? If you will be so kind and raise your hand under the participant icon. We have Delegate Johnson.
Thank you, Madam Chairman. Thank you, Doctor, for coming and explaining the bill. My question is, do we not do this already for like HIV incidences with our first responders?
So Delegate, I can answer that. We already do that with different viruses like HIV or rabies. So this would be essentially adding COVID-19 to that list.
All right, thank you. Thank you, Madam Chair.
My pleasure. Any further questions for this panel? Seeing none, thank you so much for being with us today. We do have an unfavorable witness, Mr. Vince McCovey. Are you here?
Vince McAvoy is not going to be with us today.
He's not going to be with us today. Okay. Well, this concludes the bill hearing on House Bill 737. Next, members, we have House Bill 836, which is going to be presented on my behalf by my amazing intern, Ashish Bibareri, and he's going to present the bill. It is titled COVID-19 Testing, Contact Tracing and Vaccination Act of 2021. And we have been working and having many bills, many meetings with the stakeholders and Senator Rosapep across the street. Good afternoon. Will you please get started?
All right. Thank you, Delegate Pena-Melnick. I really appreciate the opportunity. Good afternoon, everybody. Good afternoon, Chairman Pendergrass, Vice Chair, and members of the Health and Government Operations Committee. My name is Ashish Bibareti, and I'm currently a medical student and also pursuing a public health degree at the Johns Hopkins School of Public Health while interning at Delegate Pena-Melnick's office. So it's truly an honor to be here. And today I'd like to discuss with you House Bill 836, the COVID-19 Testing, Tracing, and Vaccination Act of 2021. Before I go into the details of the bill, I kind of want to take a moment to describe our current situation. Yesterday, as I tuned into the news, we as a nation hit 500,000 deaths. And that's too many. And although the virus is deadly, part of that death toll can be attributed to a lack of a coordinated response. Our government has a responsibility to help our citizens and also protect their health. And this applies to the state of Maryland as well. Currently, the caseload is approximately 377,000, approaching 7,600 deaths. And our Prince George's and Montgomery counties are hit the hardest here. So not only is this pandemic affecting our state tremendously, it is also disproportionately affecting everybody. And this is why the inception of House Bill 836 began. We need a coordinated effort for three big domains of the pandemic response: testing, tracing, and vaccination. So starting with testing, our bill proposes that we hit a target number of tests per day and also provide the necessary testing locations in each local jurisdiction. By doing so, we're not only able to catch the individuals testing positive and directing them to the appropriate health services, we're also increasing access to testing. And we want to do this with our public sectors and partners from the State Department, but we also want to encourage partnerships and better collaborations with private providers, pharmacies, and different employers. And then the next part of the bill is the tracing. And tracing is very important, especially during these times, because as we've noticed recently, the trend is going down with the cases. So the contact tracing is most effective when we have a manageable caseload. With the robust contact tracing system, we're able to identify and report those individuals who have been exposed and who have been tested positive to mitigate the test of spread of COVID.
Question.
And then the last part of the bill, the main part of the bill, is the vaccine distribution. We could do a better job with vaccine distribution. Currently, our neighboring states, West Virginia, Virginia, North Carolina, they're doing much better in terms of distribution and administration of doses. In Maryland, we don't have a centralized system yet. We need to have a centralized and coordinated system. We need to prioritize those vulnerable populations and make sure everybody who is an appropriate candidate for the vaccine gets the vaccine. And currently, currently we have close to 30% of our population made up by the African-American community, but only 16% of them are being vaccinated. We have to address these disparities. In addition to these three main phases, we also propose a public health job corps, which comprises of individuals from various health sectors that have been displaced from their jobs due to the pandemic and are able to contribute to our public health efforts. We also propose a pandemic response work group, providing monthly reports to the State Assembly on how to better respond to the pandemic. And then we urge and request our senior communities, our home health services, assisted living programs, and nursing homes to have a comprehensive COVID testing plan so they can protect their residents and their staff. And so I'd like to conclude by saying that we're in a public health crisis. Timing is everything. And we cannot afford to lose more lives. We need a coordinated response. And as legislators, we need to propose and pass effective legislation that helps and protects the lives of our citizens. And I respectfully conclude my testimony with a favorable report. Thank you.
Thank you very much for your testimony. We really appreciate it. And I also want to take a minute to welcome our wonderful appropriations colleague, Delegate Resnick, Valentino Smith, and Mangione. Thank you for being with us today. Next we have, and we do questions at the end, so just hold on, don't leave. Next we have Mr. Zachary Berger. Mr. Berger, will you be so kind and give your testimony to the committee, please?
After several emails, Mr. Berger is not with us in the room.
Okay, great. Mr. Joseph DeMatos?
Madam Chair, Madam Vice Chair, members of the Health Government Operations Committee, and those delegates from Appropriations, it's so good to look at the screen and to see your faces. Thank you so much for all that you do. You have our written testimony in support of House Bill 836. I'd like to just summarize a few points, and I would like to invite questions on any subject related to testing, vaccination, or infectious disease protocol at the end. As you know, we've been living this pretty much 24/7 since we issued our first alert on this subject on January 29th. So a couple of quick points. We've been on the front lines of fighting this pandemic since February. This time last year, there wasn't any testing capacity. You would have to have taken a CDC test from the state of Maryland lab in order to be tested. In April, in March, select nursing homes began working with hospital partners to do testing. From April to August, the state provided testing, coordinated, and paid for it. After August, skilled nursing and rehab centers at various times as well as assisted livings, have been required to test 1 or 2 or sometimes 3 times a week. Those tests are expensive, both in terms of labor hours and in terms of the cost of the tests. That's in our testimony. Testing is extraordinarily important because we know then where the disease is and where it's going. And that's not only important in our sector, but as the bill sponsors and the staffer just pointed out, it's important because this virus disproportionately attacks and kills people who come from diverse backgrounds, who are older and have pre-existing conditions. I'll share more about vaccination, testing, and infectious disease protocols in the Q&A.
Thank you. Thank you very much. Next, we have Ms. Nicole Stallings.
Great, thank you, Madam Chair, members of the committee. For the record, Nicole Stallings on behalf of the Maryland Hospital Association in support of House Bill 836. Next week marks 1 year since Maryland's hospitals saw their very first COVID patients. And in that time, they have cared for over 34,000 of our family, our friends, and our neighbors. And 1 year later, the pandemic continues to take a heavy toll on our healthcare infrastructure. And we know that we still have a long way to go. Our experience thus far shows that the challenges posed by COVID-19 will continue to evolve and will require the state to continually assess and adjust plans that suit the unique circumstances and challenges and needs of communities, of every community in Maryland. And so we can't take our eye off the ball. We must continue to closely monitor signs of spread. As mentioned, failing to do so without adequate testing or tracing really means we only notice these problems when we begin to see crowded emergency rooms. And at that point, it's too late potentially to avoid another large-scale community spread, and that will overwhelm an already strained healthcare system. And every aspect of our healthcare system is strained right now, early on, because of resources, testing, and PPE. And one challenge that has persisted across these surges is the strain on our workforce. And we were very pleased to see the opportunity to strengthen that workforce with the Public Health Job Corps. When we met with the sponsors early on to describe the COVID response, I used the word patchwork, a patchwork of requirements and policies that made an already difficult situation for healthcare providers even harder. This legislation recognizes that the path forward cannot be a series of well-intentioned but disparate policies, and for these reasons, we urge a favorable report. Thank you.
Thank you for your testimony today. I'm going to, next we have a favorable with amendment panel, and I'll wait for that. For this particular panel, are there any questions? We have Delegate Kelly.
Thank you, Madam Chair. And I'm not sure who to direct this question to. I just want to, I guess, to you or to your staffer who presented the bill, wanted to make sure, I know you're very good at working collaboratively with stakeholders, wanted to draw your attention to the Maryland Association of Community Colleges testimony. I know they've reached out to my office and they are interested in working with us to make sure that the intent of testing for higher education it works with their model. So they may need some language similar to what you put into Olivia's law to make sure that the community college model, which is different from the model of education institutions that have dormitories, have a different method for testing. So
Absolutely, we're always open to, for discussion and to meet. Thank you for bringing it up to our attention. We did not know. Thank you so much.
Absolutely.
Next, we have Delegate Valentino Smith, followed by Delegate Collison.
Thank you, Madam Vice Chair, and it's always a pleasure for us to be here with you. To start, I just exited out, as did Delegate Resnick and the other appropriation members, from the briefing on the supplemental budget. So as you work through this, we can report that they just dropped in 1.5 billion, but that they still have 1.1 billion that they need to drop in and spend. So the two areas that I just wanted to ask that we are hearing in some of the health budgets, as you work towards a centralized approach to monitor, prevent, and mitigate the spread, that in addition to testing, tracing, and vaccination, that maybe we still do some kind of centralized effort at PPE, because we did hear and take some hearings on that there were decentralized ways to get PPE at the county levels to our residential treatment centers, to our home-based community providers, and that we do have a stockpile, and that maybe as long as we're forcing a more centralized approach to this, that we add PPE into that. And then the second area that we've seen them struggle with in the budgets is their platforms for communication and the website development, and whether or not some of this big approach to the monitoring, prevention, and mitigating require a communications process that's coordinated and has a single point of entry that includes both maybe a web-based and a centralized telephone communication system for all of this. And so those are just two areas that we've at least seen in the health budget, some weaknesses, and really appreciate the opportunity to be here. Thank you.
Absolutely. We look forward. HGO gets along well with others, so we look forward to working with you and welcome it. Thank you so much. I appreciate your comments. We do have another witness that I was just told unfavorable. We had called him and he wasn't there, but he's here now, Mr. Zachary Berger. Why don't we let him give his testimony and then we'll continue with the questions. Mr. Berger.
Thank you.
He's
And
a practicing physician.
I apologize, just to close my door so I can take my mask off. I apologize for the delay. I'm a primary care physician at two sites, but the site at which I see patients that's most relevant is at Esperanza Central Health Clinic, which is a health center in Baltimore for undocumented immigrants. And both in the inpatient and outpatient setting, I have seen the effects of the lack of planning that has characterized our state's approach to COVID, both in testing and in treatment and in vaccination. Therefore, I was very happy to see this bill, which helps provide a plan and an approach that has been lacking in our state's approach to COVID. Two things that excite me most about this bill. One is the necessity for outreach with regard to vaccinations, and the second is the public health core, which is parallel to proposals that have been made on the national level. We know that public health requires people on the ground invested in communities and with individual approaches. We don't need more mass testing sites. We need more mobile or mass vaccination sites. We need more mobile vaccinations brought to the people. We need people that are hired from the communities to talk to people and to provide people what they need. That's the only way we're going to get ahead of this pandemic and really provide the structure that's been lacking from the health department and from state leadership. So again, I'm really here in strong support of this bill and strong support of the sponsors of this bill, and would love to serve in any way I can to provide advice from an on the ground perspective, helping people with COVID and trying to get vaccinations to those who deserve them, which is everybody, especially our most vulnerable Marylanders who have been underserved by the state's slapdash approach to COVID heretofore. So thank you very much for giving me the time to speak, and I apologize again for the delay in being here. Thank you.
Thank you. Thank you for being with us today. Next, we have Delegate Collison.
Thank you, Madam Chair.
My pleasure.
We had this bill a year ago, and because it really is a comprehensive approach, and I appreciate that. I do think, though, now we are a year later, and so we have some experiences, and we're in a sort of a different place. So I'm wondering about the testing aspects of the bill, and that while there's still a need for testing, it's not at the same level as it was. So I guess the insurance carriers all stepped up during the pandemic, and they've been paying for everything. I am wondering if the grant money could be used for the testing as opposed to requiring the carriers to bear the burden. I'm worried about what that ultimately does to the cost of insurance and ultimately premiums. So if it doesn't have that effect, then I'm not worried about it. But if it does, then I am.
Yeah. I don't know that it has that effect, but as you know, the bill is yours now. It's the committee's. So, And as it was told, we're getting a lot of money from the federal government to do this
Right.
work. So, it's beautiful when the money's not an issue, right? So
Right.
I am flexible and the bill belongs to the committee.
Thank you, Madam Chair.
My pleasure. Are there any other questions for this particular panel? Delegate Lewis.
Thank you, Madam Chair. Thank you for bringing this important bill.
My pleasure.
I hope I'm directing this question to the right folks. I'd like to know whether there's been any consideration to building on the incredible cadres of personnel and systems that we've already built in Maryland to strengthen what we do with regards to COVID and whatever the next pandemic is. I'm thinking specifically of Maryland's community health worker ecosystem that we're building. I'm thinking also of the absolutely incredible software technology that was built by the Maryland Health Benefit Exchange to manage the exchange, and the systems that were expanded there to incorporate the state's Medicaid system. Like, we've already got these incredible tools at hand that we could use to build on. Have we thought about integrating those as we look forward to strengthening our COVID approach, our pandemic approach?
I think it's a great idea, and there's room in the bill, right? Because it's not prescriptive with everything, and they have to develop this plan and create a committee and a job corps. So there's definitely room to incorporate them, and it makes sense.
Thank you, ma'am.
Thank you. Next, we have Delegate Krebs.
Thank you, Madam Chair. And I had a similar type of question. I mean,
My pleasure.
there's no one that does not think that there's room for improvement, probably including the administration of the 50 states where they've had to jump on board very little, no notice at all into something unprecedented in our lifetimes. But how do we take I'm not sure if you've done it, but how do we take what's already on the ground and open up the ability to communicate with other people, what's working, what's not working, what's need to be improved, and transparency. I mean, the issue I think a lot of us have right now is with the transparency piece regarding the vaccinations and how they're being distributed. But things keep changing, and how do we make sure that this single document that we aren't as prescriptive as we are with we need more overarching terms of how we would move forward. And I haven't had time to read the bill. It's the first I've seen it, but I think we know what the problems are. How do we make sure we're not too prescriptive as we're doing this, and make sure we're working with every jurisdiction is different, the small jurisdictions versus the big jurisdictions. So I know my question is very broad, but this is a big piece of legislation, which I think, there's some room for some improvement, but how do we get our arms around what the needs really are?
So in the bill, there's actually there's a clause that allows the individual health departments to do their own program. So we're very mindful of what you just said. In addition to that, the Department of Health is involved at every step in the bill. And actually, they reached out to us yesterday, which was wonderful. The administration, we met with Dr. Chan, with Jake, with Kiffer, to basically discuss the bill. And while they're not supporting it or objecting to it, they said that they would, love to work with us and work on what's in the bill. So it was very positive.
Good, and I hope to be a part of that, because I think there's some room for improvement, but I just got to be careful how we do it.
Absolutely, we get you. Thank you. Delegate Saab.
Thank you, Madam Chairman.
My pleasure.
The fiscal note, and if it's a study, why there's such a large fiscal note, and also the grants to local jurisdictions, how will they be determined? But it says here that there's at least 25 million in grants to expand the capacity of testing. Is it just divided evenly between 24 jurisdictions, or how?
So no, so I'm going to allow Ashish. I know Ashish, you're jumping. Do you want to answer that one? Go ahead.
Right. So in terms of the grants, not only for testing, but the other allocations, the money will be provided in proportion to the population of each jurisdiction. And if those jurisdictions do end up using all their grant money, additional funding will be provided based on that necessary, those necessary needs faced by those individual jurisdictions.
And what about the fiscal note jumping from 54 million to 98 million? Where does that go?
Right. So, so in terms of the fiscal note, this bill does not have a mandate on the fiscal, like on the budget. It's setting expectations. So what we're doing is in the outline in the bill, all those numbers that we are projecting or recommending, those are expectations that are going to be set by the bills to accommodate those testing, tracing, and vaccination efforts. The money will be coming in from the federal and the state funds as decided.
And Delegate Saab, we actually anticipated that question and we talked to Simon and he gave us that answer.
Thank you.
Our pleasure. Chairman Pendergrass.
Thank you, Madam Chairman. Madam Chair, can you tell me when this bill was read across the desk of the House of Delegates? Do you know offhand?
It was actually read across the desk towards the end of the deadline because it took a while to draft it. It's you know, it's a big bill and we were working with a lot of different people. I don't recall the date, but it was towards the end of the deadline.
I ask because it's much appreciated that the administration has chosen to come to you yesterday to work with you, but I am wondering why we did not hear from them sooner. I'm wondering how committed they are to working on this. I hope they're very committed. And I know that in your subcommittee, there will be plenty of interaction and also with the people who are here from the Appropriations Committee. I don't know if they feel like they want to attend subcommittees, but I would like to just welcome them to attend your subcommittees when you're doing this particular subject, because that's most helpful. So thank you for this bill.
Thank you. Thank you, Madam Chairman. Next, we have Delegate Johnson.
Thank you, Madam Chair, and thank you folks
My pleasure.
to present this bill. My question is, we were just told that the funding is going to be broken down as per the population in all the jurisdictions. So while we want to get everyone tested, we have seen with the vaccines where people have crossed county lines and taken resources from one county. Even though we want to get people tested, we want to get people vaccinated. So is the ability to go back to the well kind of speaking, is that taking that into account, the consideration that people may cross county lines to use resources that were distributed to other counties?
I think that, you know, we don't address that per se in the bill, but this is going to be collaboration with the health departments and the Department of Health. So I'm sure they can discuss it. There's nothing in the bill that says that they cannot take that into consideration. And it's something as if it is, you know, assigned to subcommittee, that we can discuss how we can incorporate it.
All right, thank you, Madam Chair.
Thank you. Thank you so much. I don't see any further questions. Thank you very much for being with us today. Next, we do have favorable with amendment. We have Ms. Dana Kaufman. Good afternoon. Will you please get started?
Thank you very much. For the record, my name is Dana Kaufman. I'm with the law firm of Schwartz, Metz & Wise, and I'm here on behalf of both Lifespan Network and the Maryland National Capital Home Care Association. I'm going to focus my comments basically on the testing portions of this bill. The bill does require a testing plan to continue for both nursing homes and assisted living, and it adds a requirement for a testing plan to be developed for home health agencies. As has been discussed already, the bill, why it does state that money should be made available to offset the cost of the testing, it is again just an expectation. and it is not a mandate, unfortunately. I was glad to hear that additional monies are coming to the state through the federal government. However, in the past, it has been our experience that when additional monies has come, the department has not put that directly to the providers. For example, the 6.2% increase in the federal match went to offset Medicaid costs for increased enrollment and did not go down to the providers. The nursing homes, of course, will be under constraints with CMS for their continued testing. But for the assisted livings and for the home health agencies, it's very important that if we're going to be having a testing policy, that there be a stronger expectation or some sort of requirement, however we need to do it with the help of appropriations, hopefully, that monies are given. Because after this year, we do have many struggling businesses trying to stay afloat, given declining revenues from census and increased costs. For the home health agencies, we do have a concern on the logistics of how this would play out in testing both their patients and their staff. Right now, they do test in facilities, but not in homes. And that does create its own unique challenges that we would like to work through with you. Thank you.
Thank you. Are there any questions for this witness? Seeing none, thank you so much for your testimony. Next, we have Mr. Matthew Santillano. Good afternoon.
Good afternoon, members of the committee. Madam Chair, thank you for the opportunity. My name is Matt.
Our pleasure.
Today, here on behalf of the League of Life and Health Insurers and AHIP, America's Health Insurance Plans, opposed as introduced to House Bill 836. We're here today with the most concern on the testing portion of the legislation, which becomes surveillance testing paid for by carriers. There's a reason that carriers pay for diagnostic testing, which is to determine illness when there is a reasonable suspicion of illness, which includes a known or suspected exposure. House Bill 836 takes all the reasonable suspicion out of the calculus and requires carriers to pay for testing regardless of exposure or symptoms. The legislation takes the concept of public health surveillance testing and tries to make the carriers the administrators. One of our concerns is that the Maryland General Assembly and the MIA only has the authority over approximately 17% of the insured lives in Maryland. This legislation won't get the desired intent. It really needs to be a state-led approach. The bill will also have the unintended consequences or result of driving healthcare costs in a negative direction, especially after this committee has done so much work to try to control cost. We're also concerned about, especially with the proliferation of at-home tests that can be expensive. Carriers will be responsible for paying for them. We're also aware that Marylanders have been using testing as a way to circumvent public health advice. Lots of people were warned to stay at home over the hospital, but they didn't listen, justifying their irresponsible behavior by getting tested before departure and upon return. This testing is not diagnostic. In addition, this use of kind of testing approach didn't start off the infection surge. Carriers would now be financially responsible for questionable behavior. Carriers are also concerned about the use of business, are we being responsible for business decisions? An example might be Stewart's Hardware in Moncton, Maryland. That's a sign that says, we test our employees once a week to sort of create consumer confidence to enter their store. Well, we don't want to discount this approach. That's the business decision of the company. Why should an insurance carrier be responsible for that business decision? Today, businesses are making this choice, cover testing as a part of their business expenses, and this bill would directly shift those costs into the insurance pool. I'll just finish up by saying we know that there is another COVID relief 19 package coming through Congress, and we know there's going to be additional money, and we think that would be best served going to the testing strategy moving forward. Thank you for the opportunity.
I'm going to wait for my colleagues to go first. We have Delegate Kipke.
Thank you, Madam Chairman.
My pleasure.
Matt Salentano, the MHA has some testimony, and I've heard from some folks that not all payers have stepped up, and there's been some denials. How would you respond to that?
That is not my understanding at all, Delegate Kipke. I think that carriers have not even done any utilization review whatsoever and been covering costs at no cost share whatsoever. There has not been any questions to a doctor. If the CPT code was sent in, carriers are paying for it. That is my understanding.
Okay, thanks.
Any other questions for this witness? I have one, and thank you so much. Good afternoon. And as always, we welcome, for you and for us to work together. I appreciate it. So the carriers didn't have to pay out millions of claims this past year due to limited access to medical care, right? Because we were in the middle of a pandemic and people were not going to the doctors. Are you going to have to address medical loss ratio requirements this year? Is that happening?
The answer, Delegate Pena-Melnick, and thank you for the question, is yes. Medical loss ratio always goes into rate review at the MIA every year when the rates are filed and when they're approved by the MIA. Two, yes, there has been a reduction in some of the costs that were utilized, but carriers are also paying at no cost share for any COVID treatment, for any testing, for a variety of things. We stepped up to the plate to try to make sure that folks were covered. Now, I don't want to say that there weren't some utilization of services that were down, but some of the services that carriers were paying for were also extremely expensive, like people that were staying in the ICU units. That's really expensive, and carriers were certainly picking up all the costs of it.
Thank you. I'd love to see those numbers at some point. Thank you so much for your testimony. Any other questions? And thank you again for being with us. We really appreciate every one of you. Next, we have, I'll try to see if Mr. McCovey is here. Mr. Vince McCovey, did he make it?
No, he won't be here today.
Okay, great. So this concludes members of testimony on House Bill 836. Thank you so much for being with us today. Next, we have House Bill 1263, Delegate Rosenberg, Maryland Department of Health, COVID-19 vaccination plan. Good afternoon, Delegate. Can you please get started?
Yes, good afternoon.
Thank you so much.
Chair and members of the committee and members with us from Appropriations. House Bill 1263 is, of course, mirrors to some degree the legislation we've just heard, not as comprehensive, but is in response to what is, for the most part, been a policy from the executive branch of responding to the latest headline and not having it would certainly appear, not having a policy that has been a structured, this is how we're going to address this problem for the long run to deal with those people in our population, those citizens of Maryland who are disproportionately sick and disproportionately not getting access to the virus, to the vaccine under existing conditions. So that, as is the case with the Chairman Pena-Melnick's bill, this bill would require that a report be prepared by the department. It is encouraging that the secondhand testimony or the testimony from the vice chair of the committee that the department is willing to work with us. They are absent today. That is not encouraging. Thus, they are unable to take questions on any aspect of these bills or any recent developments regarding these bills. What House Bill 1263 would do is specific requirements for that long-term plan, such as I pointed out, the categories of residents of the state who would be addressed, target metrics for vaccinating residents, and a dedication of time and resources to assist seniors who are a high priority to be assisted because of their vulnerability, but yet are low likelihood to take advantage of. Even if we have a one-stop portal, they are less likely to take advantage of it. Let me just conclude by saying I look forward to working with the committee and with our colleagues from Appropriations. This is the most important task we have before us to address this pandemic, to do so in a way that reduces the risk now that we have a vaccine that is proven to be successful, and also to do this in a way that looks ahead to the next time, because we need to prepare for the next pandemic so that we aren't responding to the crisis, but to be prepared for that. And as pointed out in prior testimony, there is federal money that is either coming to us under existing programs or will be coming to us under the legislation now being considered by the Congress, so that we need to make sure that through the budget process or through the statutory process that that money is being spent appropriately. So I look forward to working with all involved on this very, very important issue, and hope that House Bill 1263 will be helpful in that process. Thank you.
Thank you, Delegate. Any questions for this witness? We have Delegate Krebs.
Thank you.
My
the sponsor,
pleasure.
the one thing, I don't know if it's in here because I haven't read it yet, but is there anything in here about the sign-up process or making a more uniform sign-up process, an accessible process, the same for everyone throughout the state? Is that in here?
I don't know that it's in there specifically, but that clearly is one of the issues that needs to be addressed. Whether there should be a uniform process or whether the process needs to be one that there are different options for different people, different categories of people. For those who have internet access, yes, one portal, that should be considered. And specifically, the bill talks about outside experts and stakeholders to be part of the process by which the health department comes up with its plan. But there might be people, there clearly are people for whom a one-stop portal is not the way to go. And so we need to take into account, we have legislation this session on the digital divide. We need to take that into account here. For those who, a one-stop portal for those who have digital access, but clearly we need other alternatives for those who don't have such access.
Thank you.
Any other questions for the delegate?
Thank you, Madam Chairman. I'm just figure out the timeline between when this bill will take effect, when it passes, and then when, so it says here that the plan must be submitted by April 1st, 2021. So maybe someone can explain to me how would that work as far as we're in, almost March now, and the bill, I'm not sure when the soonest this bill will pass. Will they have enough time by April 1st to submit the form? To submit the plan?
Well, those are discussions that should have begun before now, but apparently have to some degree begun with the department's expression of its willingness. We can adjust that date. The key is having a plan that addresses the needs for all Marylanders. That's what's crucial here, and we can adjust the date. But the key is having a plan that is thinking ahead and not just responding, as I pointed out, to the crisis at the moment.
I appreciate that. And I think we definitely need that. I just want to make sure that they don't like the plan that's not good and then we start over. So I appreciate it. Thank you.
Thank you.
Any other questions? None. Thank you, Delegate Rosenberg. And this concludes the bill hearing on House Bill 1263. Next, we have House Bill 1313, Delegate Maggioni. Good afternoon.
Yep, thank you. Good afternoon, Madam Chair Pendergrass, Madam Vice Chair Pena-Melnick, and the members of the committee for allowing me to present HB 1313, which is the Emergency Medical Services Paramedics Vaccination Administration. And this is a cross-file from Senate Bill 67, and it comes at the request of the Maryland Institute for Emergency Medical Services Systems. And the good news is this bill has already passed the Senate with a vote count of 44-1. So to briefly explain, before I allow the health experts to add much more detail and better suited to answer any questions than I would, that this emergency departmental bill, it authorizes a paramedic to administer vaccinations included on the CDC's recommended adult immunization schedule or authorized for emergency use by the FDA. And what's really important to note is that those services, it must be part of a public safety or commercial emergency medical service, occupational health program, or a population health outreach effort conducted by the appropriate local health departments or hospital or health system in the state. So basically it means that, you know, these EMS workers, they're not setting up in the Annapolis Mall to administer vaccines to random people. So what you have, hospital and health systems here, they worked very hard and very timely as possible to establish clinics to distribute vaccines for their staff. And now, as we know, they've been preparing, trying their best to vaccinate the communities at large here. But one of the challenges with the efforts to ramp up vaccinations is that it is limited by a lack of staff to administer the actual vaccines. So what HB 1313 will allow is for the EMS providers to fully participate in COVID public health efforts beyond the emergency declaration and deploy for any public health vaccination effort needed in the future for potential catastrophic health crises or regular public health efforts. So basically, from a local perspective here, to kind of help summarize what this means is in Baltimore County, for example, who supports this legislation, they basically say it would allow for more eligible vaccinators and help county agencies to be prepared to vaccinate the local populations efficiently and quickly. And that, of course, is the intent throughout the entire state that this bill could provide. So with that, I would like to welcome some of the experts to speak on this bill. Thank you, Madam Chair.
My pleasure, and we'll give your time to your expert, Mr. Theodore Delbridge.
Hi there. Again, good afternoon, Madam Vice Chair and committee members. Dr. Delbridge on behalf of the Maryland Institute for Emergency Medical Services Systems. And I would just like to point out that the current law was enacted in 2000, a generation ago, authorizing paramedics to administer influenza and hepatitis vaccines and TB skin tests as part of occupational health programs, or basically involving other public safety personnel. It didn't include paramedics who work for commercial ambulance services, and it didn't anticipate the need for additional vaccines. It also doesn't account for paramedics as potential public health force multipliers. House Bill 1313 provides a framework for paramedics to administer additional vaccines, those included on the CDC's recommended schedule for adults. It includes paramedics working within commercial ambulance services. It emphasizes requiring oversight by an EMS medical director or other qualified physician. It requires approval by MEMS, and it requires a partnership between the EMS agency and the local health department or a hospital or healthcare system. I'd like to stress that this is EMS as a force multiplier, assisting local health departments to fulfill their missions, not embarking out on their own, not acting independently, but in collaborative partnerships, and in all cases, providing oversight by a physician. The COVID-19 pandemic, as you all have been discussing, stresses the importance of this, but it's not limited to that. There are other seasonal things that are relevant, and we need to prepare for the next eventuality, whatever that might be. And so for those reasons, MEMS requests a favorable report for House Bill 1313. Thanks.
Our pleasure. Thank you for being with us today. So this is the panel of favorable. Are there any questions for them? Delegate Hill.
Thank you very much. Looks like a very smart bill. I guess, Mr. Delbridge, can you just explain to me in the committee why is this different from just having EMS personnel sign up through the Medical Reserve Corps to provide vaccination services? How does this work? Is it more efficient, different?
Well, EMTs and paramedics in the state are authorized to practice by way of an EMS medical director. And this keeps them under the auspices of the medical director and ensures that their practices, that what they are doing is appropriately vetted by a medical professional, as opposed to them embarking out into independent practice, which they're not authorized to do.
Thank you.
Thank you very much. Are there any other questions? Delegate Saab.
Thank you, Madam Chairman. One of my questions in regard to the Attorney General's letter of information regarding reimbursement. So if the EMT is actually performing the vaccine, who pays for it? And will the patient know that they might get a bill from the insurance company, or how would it work? Because they're not credentialed typically with a provider, with an insurance company carrier.
Well, in all these cases, I think it depends under the circumstances under which they're doing what they're doing. So in the current state, I'll use, for example, Anne Arundel County Fire Department, which is in collaboration with the local health department to administer COVID-19 vaccines, as one example. And in all such cases, it would fall under whatever the reimbursement options exist for that particular effort. And so I don't know that I can provide a blanket statement in terms of how billing and reimbursement would be handled. I think it depends under the circumstances under which the vaccine is being provided.
I'm just concerned that patients will actually end up getting a bill and not knowing, or thinking just because an EMT performed the vaccine that it's not, a billable service, which it is.
Yeah, I'm not. I understand that concern, and I appreciate the issue. I don't think that is likely eventuality, because in all such, first of all, I think in all cases where a bill for services was at all contemplated, the patient would have to provide the appropriate information of a third-party payer to be able to make that happen. And these are cases where that's not likely to be the case. These are all public health. I mean, what we're discussing are public health initiatives, and not a case where, for example, EMS is going out on their own to provide a service for which they're then going to send the patient a bill.
Thank you. Thank you, Madam Chairman.
My pleasure. Chairman Pendergrass.
Thank you, Madam
My
Chair.
pleasure.
I'm trying to figure out how the bill, and I haven't read it carefully, how it guarantees that these EMTs are working in a coordinated with, under the, I don't want to say supervision, but under the organizational umbrella of the local health department. Can you explain that to me?
Because it requires, yes, ma'am, and I appreciate that question, and that's our goal. It requires that they are functioning within the construct of the EMS agency with which they're affiliated, and that agency and its EMS medical director and MEMS all have to sign off on the appropriateness of the collaboration. And so in Maryland, as EMTs, and in this particular case, just paramedics, are authorized to practice, they have to have that affiliation in order to be able to do their thing. Otherwise, they're functioning outside the law.
So I'm thinking that it would be more direct if the health officer in the location had the control over that, because that's who we want to make sure they're working with.
Well, we're not really contemplating an individual paramedic making an arrangement with the local health department to do the service. We are contemplating the EMS agency, for example, Anne Arundel County Fire Department or Baltimore County Fire Department, having that relationship and enabling the paramedics that are affiliated with that organization to be the agent that actually administers the test, administers the vaccine. We're not advocating for paramedics to be independent agents that collaborate with another physician to do what it is we're contemplating. Again, in all cases, what authorizes a paramedic in the state of Maryland to practice is authorization by an EMS medical director, one of 26 physicians in the state who authorize the practice of the people and who vet their competence to be able to do that. We are not advocating for paramedics to be able to form independent relationships with other physicians in the state to do what it is they're unable to do. That would amount to a much larger change than we're contemplating.
Any other questions? Seeing none, thank you so much for being with us today. We have now a panel of favorable with amendment. The first witness is Ms. Erin Dorian. Good afternoon, Erin.
Good afternoon, and thank you, Madam Vice Chair and members of the committee.
My pleasure.
For the record, my name is Erin Dorian. I'm the Director of Government Affairs and Policy at the Maryland Hospital Association, here in support of House Bill 1313. For nearly a year, Maryland's healthcare heroes, including EMS providers, have been on the front lines of the COVID-19 pandemic. Now, as the state, local health departments, and hospitals ramp up vaccination efforts, it's important to ensure adequate workforce to administer these vaccines. Under the current governor's proclamation of a state of emergency and a catastrophic health emergency, currently in effect, paramedics can administer COVID-19 vaccinations. However, after that expires, the state of emergency ends, the need for mass vaccination efforts will continue. Maryland needs every available qualified practitioner to be able to administer these vaccines. One additional note I'd like to make, and something that was actually came to mind in the earlier testimony on your bill, Madam Vice Chair, was that in many communities, paramedics are important and trusted healthcare professionals. Engaging these providers in vaccination efforts could facilitate the improvement of community trust of vaccines. House Bill 1313 allows EMS providers to fully participate in public health efforts beyond the emergency declaration. These providers will be ready to deploy for any public health vaccination effort needed in the future for a catastrophic health crisis or just a normal public health effort. For these reasons, I urge a favorable report of House Bill 1313. And I believe the amendments that you are referring to, that we are favorable with amendments, are actually amendments that MIMS has written up in their testimony that are needed for clarification on the bill.
Thank you. And colleagues, will you be so kind and mute yourself if you're not muted? Thank you so much. If you can please mute yourself. Thank you. Next, we have Ms. Emily Tarcell.
Okay, can you hear me?
Yes, we can, clearly. Good afternoon.
Good afternoon. Good afternoon, Madam Chairman and Vice Chair and delegates. I'm Emily Tarcell. I represent Health Choice Maryland, and it seems reasonable to authorize EMS to give COVID-19 vaccinations to increase the number of providers in an emergency, as long as consumers are given informed consent and are told in this experimental vaccine and they can opt out. We do, however, have concerns about the broad expansion of authorizations for vaccinating, because whether or not to vaccinate is a decision to be made between a patient and their doctor in the context of their unique health history, and EM providers are not doctors. Vaccines are major medical interventions that can have serious outcomes for some people. The Institute of Medicine has stated, quote, vaccines are unavoidably unsafe, quote. I experienced a personal loss when my 1-year-old daughter died from the HPV vaccination, and the government has conceded she died from Gardasil. There are 3 times as many adverse event reports for Gardasil as there are for all other vaccines combined, and a recent peer-reviewed paper titled The Expanding Cocktail of Harmful Ingredients in HPV Vaccine documents that Gardasil contains a toxic chemical used in biological warfare, and there are major lawsuits across the country pending. In short, for vaccines, HPV vaccines were also not tested for interaction with other vaccines. So we see no need to authorize EMS to give HPV vaccines, or indeed maybe other vaccines that are readily available at a lower cost elsewhere. So we urge the bill be amended to authorize administering COVID vaccinations only, and the authorization expire at the end of the pandemic. I thank you very much.
Thank you for being with us, and I am very sorry for your loss, all right? We really appreciate your time. Next, we have Ms. Jill Caper.
Hello, good afternoon.
Good afternoon, how are you? Can you please get started, and welcome to
Yes.
our.
Thank you. I support this bill if amended to be for COVID-19 vaccines only, if provided informed consent, and if consumers can opt out. Generally, vaccines are not needed for emergency situations. I believe there is also a likelihood that it would add to the healthcare cost regarding the administration of the vaccines by paying for EMS to deliver the vaccines, which could be obtained elsewhere for less money. And that's it. Thank you.
Thank you for being here. Are there any questions for this panel? Seeing none, thank you very much for being with us today. We really appreciate your testimony. And colleagues, this concludes the testimony on House Bill 1313. Next, we have House Bill 812, Delegate Collison, Maryland Department of Health, 211 Maryland Mental Health Services Phone Call Program. Good afternoon, Delegate Collison. You're muted.
There we go.
I know, I do it all the time.
Thank you very much, Madam Chair, and Madam Chairman Pendergrass and members of the committee. Thank you for the opportunity to present this bill to you today, which basically creates a program to address the needs that we see that are ongoing and increasing with respect to the mental health needs of our fellow Marylanders. In the last year, I've personally experienced seeing two families that I know and care about suffer incredible loss because of the death of a family member who committed suicide. You know, we all grieve when we lose someone, but when we lose someone by suicide, we are always left wondering, what could we have done? What should we have done? And ultimately it was that person's decision, but the survivors are always left wondering. In this committee, we're asked every year what we can do, what programs and policies can we put in place to help to make more resources available for individuals who are suffering from mental health and from mental health disorders. And we've answered that call in many different ways. For example, there are a number of state-sponsored crisis hotlines, including the 211 Press 1. In that program, 211 Maryland partners with the State Behavioral Health Administration and Maryland Mind Health and Maryland Salud Mental to provide supportive texts and mental health resource information. To benefit from this service, an individual contacts 211 Press 1 by phone, by text or internet. With this bill, we're going a little bit further, because now we're asking you to support another program, one that we believe will proactively support an individual who is struggling so that they do not reach a crisis point. When mental health issues have existed throughout history of human beings, we know that, but it's only been in recent decades that we've acknowledged and treated them like a legitimate healthcare issue. In the 211 annual report of 2020, over 64,000 Marylanders were provided connections and information about where to get mental health services. That's just on 211 Maryland. An additional 52,000 responses were for folks in suicide crisis or emotional distress. 52,000. In FY13, that number was 7,000. 7,000 just 7 years ago, 52,000 this year. And the pandemic has certainly contributed to the increase in FY20, but the annual increase over FY19 was about 10,000. So it's, you know, while it's increased, it's not all due to the pandemic. Marylanders are asking for help, and they were before COVID-19. Depression can affect everyone at any age. And the suicide rate in the country has increased by 35% over the last 20 years. We've put programs in place, but it's still overwhelming. So what can we do to help? Several years ago, we passed the senior call-in program, where any senior who registered can receive a daily automated call. If they don't answer, their emergency contact is contacted. This program would run in a more personal way. A person would register and then receive a live person call from a trained provider just to check in. And the regularity of that call would be determined between the 211 call center and the individual itself. And if the individual is in crisis or needs support, they will be able to access it immediately. If they're looking for other supports that they can access, then and they're not in crisis, then it's a friendly check-in call. I've spoken to you many times about the value of 211 Maryland and their evidence to step up on behalf of our residents. I want to thank Executive Director Quentin Askew for his work and Senator Zucker, or with Senator Zucker and myself, to make this program available. You know, they give us a report every year, and I won't be surprised if this program is implemented. In our annual report for 2021, we'll see the value of this program and consider that we might want to expand it to others, even like folks who are suffering from substance abuse. Thank you very much for your consideration of this bill. And on behalf of Marylanders who suffer from mental health, who need mental health services, I respectfully request a favorable report. And I'll turn over the panel over to Quentin now.
Quentin Askew, good afternoon.
Good afternoon, Madam Vice Chair.
Good afternoon.
Thank you, and good afternoon, other honorable members of this committee. Thank you for the opportunity to comment in support of House Bill 812 Mental Health Services Phone Call Program. This proposed legislation does several things, including providing proactive support to reduce an individual's crisis, connecting them with a crisis specialist when needed, and improved access and direct connection with behavioral health and mental health crisis. Marylanders who choose to opt into this service or follow-up call will be able to access this through 3 simple, easy ways. SMS text, easily text a created keyword to 898211, online through an automated registration form, or simply dial 211 to connect to an automated callback feature. Marylanders who opt in will be supported by one of our call center network specialists who will assess their needs and link to the appropriate resource. Our network of call centers has extensive experience in mental health, first aid, and trauma-informed care. They are nationally accredited through American Association of Suicidology, Alliance of Information and Referral Systems, CARF accreditation, the International Council of Helplines, and they support the National Suicide Prevention Hotline. Nationally, 211 is recognized as the most comprehensive source of locally curated resources. Since the pandemic, 211 Maryland has been the state's central connector to health and human services throughout, as the delegate mentioned. During these difficult times, it's really important that Marylanders know that they are not alone and help is needed. This legislation will provide a lifeline and empathetic voice to many who are in need. As someone who has lost a loved one last month to suicide, I understand the toll that it takes on a family. And I urge you to consider the positive statewide impact this legislation will have and request a favorable response. Thank you for the opportunity to provide this testimony. Thank you, Delegate Kellison, and I welcome any questions.
Thank you for being with us today. Next, we have Ms. Emily Allen. Ms. Allen, good afternoon.
Good afternoon, Madam Chair, Vice Chair, members of the committee, and the members that are visiting this committee today as well. My name is Emily Allen. I am the Public Policy Associate at the Mental Health Association of Maryland, here in support of HB 812. This bill would provide a vital resource for Marylanders who've been struggling with their mental health, both long-term and as a result of the COVID-19 pandemic. Even before the pandemic began, as the delegate said, studies have showed us that youth mental health has been worsening and the prevalence of mental illness and suicidal ideation among adults was increasing. During the pandemic, 40% of adults in the United States have reported symptoms of anxiety or depressive disorder, which is up from 10% in 2019. In Maryland, rates of anxiety and depression have ranged from 25% to 40% throughout the pandemic. Many are reporting difficulty sleeping, increases in alcohol consumption or substance use, and worsening chronic conditions due to worry and stress resulting from the pandemic. Adults have faced significant loss of income, and research tells us that job loss is associated with worsened mental health issues. Families with children have faced challenges with school closures and lack of childcare. And then there's all we've asked of our essential workers over the past year. This problem is not going to go away as the pandemic subsides. New studies in the United States have shown us that those who were sick with COVID-19 had a significant chance of developing a psychiatric disorder after recovering. And studies from other countries, including the United Kingdom and Ecuador, have seen increased rates of mental health issues following a COVID-19 diagnosis as well, including depression, anxiety, and post-traumatic stress disorder. Similar small-scale programs to what this bill would establish already exist throughout the state. American Legion has buddy checks for veterans with mental health concerns. Frederick County's Mental Health Association has calls to senior citizens, and Baltimore Neighbors Network provides emotional support calls to Baltimore's residents. This program would fill the gaps for Maryland citizens that are struggling with their mental health that aren't already able to be served by those other programs. And with that, I urge a favorable report.
Thank you. Next, we have Ms. Cyphers. Good afternoon.
Good afternoon, Madam Vice Chair and members of the Health and Government Operations Committee. Maura Cyphers with Compass Government Relations. I'm here on behalf of NAMI Maryland. NAMI is the National Alliance on Mental Illness. NAMI strongly supports this bill. And just to provide a little bit of additional context, NAMI runs a statewide helpline. Calls into their helpline are way up. Staff is working around the clock to address the calls from their members. And it's not just isolation and depression and anxiety. The pandemic has really compounded life's difficulties for people with a mental illness. So if you're facing unemployment or housing instability, hunger issues, it makes getting help and staying in treatment even that much harder. And so I think this personal connection and what Quentin does at 211 is really incredible. And a service where people can opt in and say, I need a little help, I need outreach, I'm not feeling great, we could not support this more. And part of what NAMI does when it's not a pandemic is they provide free programming, free support groups for individuals with mental illness and their family members in the community. And I think this is a support and a resource that we would love to help promote and provide to our members so that they know and they can utilize. And the last thing I just wanted to highlight is when we met with the bill sponsors and Quentin a while ago, he mentioned it might be possible to work in texting. And I think just thinking about suicide, I think is the highest cause of death for people aged 10 to 34. And so when we think about what modalities of communication different generations are comfortable with, making sure that we're utilizing a tool that's effective and impactful in many different ways as possible is something we'd encourage you to consider. Thank you so much.
Thank you for being with us. Are there any questions for this panel? We have first Delegate Rosenberg.
Thank you, Madam Chair.
My pleasure.
For whoever on the panel wishes to speak, has this been done in another state? It sounds like a great program, but do we have any evidence of that? It's having been done and the benefits in another state.
Quentin, do you have any information on that?
There are current additional support texts that are provided in New Jersey and Atlanta. I don't have the specific data, but that is something that we can gather. But there are other states that have been replicating this effort, as well as using text to support those for behavioral health.
Thank you. Next, we have Delegate Krebs.
Thank you, Madam Chair.
My pleasure.
I'd like to ask either Quentin or the sponsor, we were briefed earlier this year at this committee on the GBRICS program, GBRICS, and I forget what the acronym stands for, but it's basically a very large multi-year grant through the HSCRC that they are, and I actually had a briefing by them on Friday, a personal briefing. It was very exciting. It's for the Baltimore metropolitan area, and they're focusing on all of these issues. And it seems like this would be a part of it. And I actually asked them about 211 and if they were familiar with what we're doing with 211. So I wanted to just ask you if you're familiar with the GBRICS program, and then also ask you if you're familiar with the work this committee has done with Next Generation 911, which would provide the ability to do the texting through as we do for 911. So this is a component, it seems like, of some of these other things, but specifically, are you guys working or familiar with the GBRICS program, grant program?
Yes, Delegate, I am familiar with the GBRICS program and have been in discussions with them as well. I've been a part of the last couple of meetings as a listening member. And so our goal, we will also be a part of that system with supporting our crisis call centers. And so the idea is really to be able to partner and work holistically with other behavioral health call centers and crisis centers, to ensure that we're all really working together to make this an effective network.
Thank you. I think it's going to be a great synergy with your groups. Thank you.
Yeah.
Any other questions or concerns? Seeing none, this concludes the bill hearing on House Bill 812. Next, we have House Bill 872, Delegate Charles, the Sheila Hickson Behavioral Health Services Matching Grant Program for service members and veterans, the establishment of the program. And with us today, we have our wonderful colleagues from the Appropriations Committee, Delegate Young, Henson, and Mangione. Welcome to our committee, and feel free to ask questions when we get there. Thank you. Go ahead, Delegate Charles.
Good afternoon, Madam Chair and honorable colleagues of the Health and Government Operations Committee. For the record, I am Delegate Nick Charles, bringing forward House Bill 872 for a favorable report. HB 872 would create a matching grant program for community-based behavioral health clinics that serve veterans, active service members, and their families. The program will be named after our former colleague, Delegate Sheila Hickson, who tragically lost her son, a Marine of 27 years, to suicide several years ago. I am pleased to have Delegate Hickson's daughter here today, who will speak in favor of the bill. On the bill, only nonprofit organizations that serve service members, veterans, and their families will be eligible for these grants. The program will be administered by the Department of Health, which will develop the application, procedures, and the selection criteria for the evaluations of the proposals. All grants will be required to be matched by the nonprofit organizations. And the bill allows but does not mandate state funding of up to $2.5 million a year towards the program. And I want to make an emphasis and repeat that this allows but does not mandate any state funds. This bill is modeled after a program in Texas that has been very successful in supporting programs that serve in the behavioral health needs of active service members and veterans in the state. Right here in Maryland, we have nearly 400,000 veterans, many of whom have been deployed to Iraq or Afghanistan for our country's war on terror, only to come home with their own terrors and have to live with PTSD and major depression. The statistics about veteran suicide in Maryland are grim and quite sad. 18% of all suicides in Maryland are veterans, and veterans are twice as likely to commit suicide as the general public. 1/8 of the veterans are by the guard and reserve members who were not activated and therefore not eligible for VA services, where they would not be able to go to the VA and get the help that they need. 62% of the veterans who take their own life are not under care of the VA at the time of their death. As you'll hear from the witnesses that follow, COVID has made this problem even more pressing, with suicide increasing to 30% among clients of as compared to before COVID. The statistics highlight that need for support for community-based behavioral health to fill the gaps when the VA is no longer there as a support system. As a veteran of the military, this bill means a lot to me, as it's a way for us as a body to truly help our veterans who have been impacted by the war on terror, the wars prior to, and it gives us an ability to truly be the helping hand that we are here to do. Speaking today in support of this bill, we have Dr. Ann Vanderbroek, Senior Vice President and Clinic Director of the Stephen A. Cohen Military Family Clinic at Easter Seals. We also have Lynn Hickson Hunter, former Delegate Sheila Hickson's daughter. We also have Melvin Graves, who will be here representing the American Legion, and Danny Farrar, who's the founder and president of Platoon 22. In addition, we have letters of support from the following individuals: Anxiety and Depression Association of America, the Elizabeth Doyle Foundation, Holy Cross Health, National Military Family Association, Warrior Canine Connection, Wounded Warrior Project, Admiral Mike Mullen, who's the former Joint Chief of Staff. We also have support from State Farm, Maryland Catholic Charities, Mental Health Association of Maryland. I say all of these names because I want you to understand that this bill has a lot of support, and we truly need to take care of our veterans. So I want to thank you so much for hearing me today. as I look for a favorable report, and I look forward to working with all of you as we move forward in the best way possible to help our Maryland veterans. Now I will turn over to my panel, starting with Ms. Vanderbroek. Thank you all.
Our pleasure. Good afternoon, Ms. Vanderbroek. Will you be so kind and address our committee? You have 2 minutes.
Thank you very much. For the record, I'm Dr. Annika Vandenbroek. I'm the Senior Vice President for Easter Seals in DC, Maryland, and Virginia, and Clinic Director for the Stephen A. Cohen Military Family Clinic at Easter Seals. Our clinic opened in 2017, and since that time, we have served over 800 individuals in 16 counties across Maryland. In my written testimony, I touch on my own military experience, but I wanted to share this morning a note that I received from an Air Force veteran that was treated in the past year for PTSD. And she'd been experiencing difficulties for nearly 20 years from her experiences in 9/11 and expressed a desire to die, saw no hope for peace or happiness in her future. Her words to me were, when I remember where I was when we met and compare my state of being now, I marvel. My much frayed past coping strategies would have buckled under the strains of today. They would have failed. It's frightening to contemplate. Our clinic has witnessed a 30% increase in the number of clients reporting thoughts of suicide and a 27% increase in requests for services since COVID. PTSD, depression, and anxiety are common problems presenting at our clinic, and they are associated with poor outcomes, and they affect every facet of life for veterans. We urge the committee to submit a favorable report on HB 872 to help save the lives of veterans and improve the quality of life for veterans, military families, and the families of active duty service members in Maryland. I hope you have the time to read some of the words of support from the people that Delegate Charles identified, and thank you very much for your time today.
Thank you, Dr. Vanderbroek. Next, Mr. Danny Farrar. Good afternoon.
Good afternoon. I'm writing in support of the Sheila Behavioral Service Matching Grant Program for service members and veterans. It calls for the creation of a state fund to provide matching grants to community-based organizations providing evidence-based behavioral health treatments to service members. As it was already mentioned, there are approximately 399,000 veterans living in Maryland, of which an estimated 24,000 have been deployed to Iraq or Afghanistan. Across the state, approximately 10,000 veterans are dealing with post-traumatic stress and major depression. We know that veterans comprise 18% of all deaths of suicide in Maryland, and this group is twice as likely as non-veterans to die by suicide. Perhaps most troubling, more than 62% of veterans who take their own life are not under the care of the VA at the time of their death. Community-based organizations play a crucial role in providing timely evidence-based services that fill the existing gaps in the VA system. Veterans have had a disparate impact from isolation caused by COVID-19, so this legislation is needed more now than ever. I know the importance of the fight firsthand, both as a suicide survivor and an advocate for the veteran community. My time in the service saw me take the first team to the Pentagon on 9/11 to secure the perimeter and remove remains. I also deployed to Iraq and conducted over 800 convoy missions in a combat environment. Upon my return stateside, I would transition horribly, bottom out. I would get fired from my first job, evicted, divorced, and homeless. I attempted to take my own life. I would spend several days locked up in the psychiatric ward in Frederick Memorial Hospital, and that would begin my road to recovery. Since then, I have founded a successful business, helped launch the nonprofit Platoon 22. We're currently slated to open our very first Veteran Services Center here on Veterans Day this year, in a partnership between Platoon and Goodwill of Monocacy Valley. It affords us the opportunities to see how those numbers in the opening letter play out. That's why I know it's absolutely vital that we support this bill. Not only do we owe it to our warfighters, but I am proof that when help is rendered, massive success can be produced. We have proven leaders in our state. Let's honor our commitment to help them so that they can help lead with their leadership again. If nothing else, 2020 has showed us we need our leaders more now than ever. Thank you.
And the committee really appreciates your service in your platoon. Thank you. We have Ms. Hunter. Good afternoon. Will you be so kind and give us your testimony? Lynn Hunter.
I forgot to unmute. I apologize.
It's
Thank
okay.
you.
It happens. Good
Thank you, Chair
afternoon.
Pendergrass and members of the committee. I'd like to start in support of my bill for House Bill 872 by sharing a little family history as to why this grant program is so important to me. My mother, Sheila Hickson, was a single mother raising 4 children on her own, 2 girls and 2 boys. As a result, we were an extremely close family and very protective of one another. Some say too close. Considering what happened to my brother, I do not think so. My mother joined the Maryland House of Delegates in 1977 and life went on. Each of us went on with our own lives, and my brother became a Marine. We were all quite different, but remained close. In 2000, we lost my older brother to cancer, which was devastating enough, only to lose my younger brother to suicide in 2010. I do not know how my mother withstood the pain of losing 2 children, but she remained strong. Therefore, we followed her shining example. My brother came home in 2010 after several tours overseas, this time in Iraq. He had only been home less than a week before he died by suicide. From the moment he came home, I knew something was wrong. He called 5 times a day, and that was unusual. He was a private person and kept personal things to himself. However, I knew he was a softie. Yet he sounded so vulnerable and saying things to himself. However, I guess I just want to say that this is still a stigma associated with mental illness and asking for help, especially in the military. By passing this bill and creating this grant program, we might be able to reach people. I thank you for your time and attention and urge the committee to submit a favorable report on House Bill 872. Thank you.
Thank you for your testimony today. Your mom is loved by all of us here. We're so
Thank you
for her service. She is a woman, and thank you.
Thank you.
Our pleasure. Next, we have Mr. Melvin Graves. Mr. Graves, are you with us?
Yes, ma'am. Thank you, Madam Vice Chair.
Our pleasure.
Distinguished members of the committee, let me just say I've sent in my written testimony, so I'm not going to go over each and everything on this written statement that has already been sent in to you. So I'm just going to speak from my heart as a veteran. Madam Vice Chair, when we see men and women on the streets, on our streets, rest assured some of them are the men and women who are veterans. So let's do the right thing for them. We find that our mental health issues, substance abuse, behavior disorders, etc. These are things that affect our veterans. As a Vietnam veteran, not only those who are coming back from the wars of today, we even have some of our Vietnam veterans who are still suffering from lack of these type of services that could be provided for them. HB 872 is the way to go to provide this type of services to our community so that we can not only bring them back to our community as a whole person, but as a productive citizen to come back into our counties and our states of Maryland. So I plead with you, I applaud with this committee, please, let's have a favorable vote for HB 872. It is just the right thing to do for those of us who are still out there and just need the help that these programs can do for them with this grant. I thank you so much.
Mr. Graves, the testimony from the heart are always the best in this committee. And as my chairman always says, you know, it's best to speak from the heart, right? So
yes, thank
you for your service as well. We really appreciate it. Are there any questions for this panel? I don't see any questions. Thank you so much for your valuable testimony. We really appreciate each and every one of you. We hope you have a great day, okay? And take good care of yourself. So that concludes the testimony on House Bill 872. Next, we have House Bill, and I want to thank also the members of the Appropriations Committee for being with us. Next, we have House Bill 889, Delegate Chen. And we have the title of it, Public Health Cottage Food Businesses Annual Revenues. Good afternoon, Delegate Chen, Vice Chairman Chen.
Good afternoon. Thank you very much, Vice Chairwoman Pena-Melnick and members of the Health and Government Operations Committee. I appreciate the opportunity to be able to present to the committee today House Bill 889. Three things I'd like to do. First of all, explain what the bill does. Second of all, talk about the cottage food business industry right now, and also what the bill would do if it was passed. What the bill does, House Bill 889, it would increase the amount of revenues that a cottage food business could make in a given year. Currently, it's at $25,000. It would increase it to $100,000. And the currently in the cottage food business, it's overseen by the Maryland Department of Health. So right now, how it would operate is a cottage food business. They would operate out of a residential house, out of someone's home, and they could produce non-hazardous products. So pastries, bread, jam. And after those products are produced, they are then distributed either to farmers markets or public events or to personal delivery from the individual, from the cottage food business to the other individual, or through various modes of deliveries. There are also options for the cottage food business to be able to market and distribute their products to the retail industry. And if that is the case, then they would complete a food safety program that is through the Maryland Department of Health. The reason for this bill is that throughout the past 11 months, it's very, very tough. And we've heard anecdotally about how home-based businesses have increased and how they've actually helped with our economy and helped to stimulate the economy on a micro level. But if you look from a macro level, it could have long-term effects. And the Maryland Department of Health, they would still have the oversight over these cottage food businesses. And thank you to the committee last year in the Maryland General Assembly, there was an additional measure put in place where that products were distributed through the cottage food businesses, they are required to have labels on them. Labels would have the maker of the product and also the ingredients and an address and contact information, so that if anything did occur, that there would be an accountability to where those products were made. Right down the street from us, not too far from us in Annapolis in the residential area, there's a cottage food business operating, and every Saturday they bring the pastries over to the farmers market, which is right down the road on Riva Road here. So that's an example of the type of local impact that's been making. And again, this is a way to help stimulate the economy. And this afternoon, we actually have that cottage food business owner who's actually going to be providing testimony about how actually he started it during the pandemic, and within a few months, he was almost able to exceed the current limits. And also to keep in mind that there's fixed and variable costs that are involved in starting up a cottage food business. And with the $25,000 limit, as far as amortization and to be able to have these different, specifically fixed costs paid off, it would go over more of a period of time as far as amortization. I think that the intent of the bill is that if the revenues are raised, that the cost of capital could also be paid off a lot sooner rather than later. So thank you so much to the Health and Government Operations Committee for considering this bill, and I appreciate consideration of a favorable report. Thank you very much.
Thank you, Delegate Chan. Next, we have Mr. Thomas Giancola. Mr. Thomas Giancola, are you here?
Yes, I am, ma'am.
Good afternoon. You can get started.
Good afternoon, ma'am.
You can get started. You can get started. Can you
thank
pass
you.
your testimony? Yes.
Yes, ma'am. Good afternoon. Thank you, Committee Chair, Vice Committee Chair, and distinguished members of this committee. My name is Tom Giancola, and I'm a home baker operating a cottage food business and I would like to ask for your support for House Bill 889. My path to becoming a cottage food baker was not planned. Prior to the pandemic, I simply enjoyed baking bread for family and friends. When the pandemic hit, overnight, I went from making 1 or 2 loaves of bread each week to making several dozen loaves each week to feed my neighbors because grocery store shelves were simply empty. After being encouraged by family and friends to continue to expand my baking, I started a cottage food business and became a vendor at my local farmer's market. I've enjoyed becoming a baker so much that my wife and I started entertaining the idea of expanding our small baking business by renovating the kitchen in our home. This would allow us to produce even more bread and pastry while we look to the future and the possibility of one day opening a brick and mortar establishment. Unfortunately, the restrictive annual sales cap for cottage food will not allow me to grow my business. Baking and selling bread once a week has not given me enough opportunity to grow my customer base, gain experience successfully managing a business, or even hire a single employee yet. Cottage food law currently limits annual sales to $25,000, making Maryland's law more restrictive than 36 other states. This restrictive sales cap is unnecessary because the Department of Health has already determined what non-hazardous foods can be safely prepared in a home kitchen. Cottage food businesses are limited to only making certain products and therefore do not compete with restaurants. As a bread baker, I can only sell at limited venues such as farmers markets and cannot offer my bread as part of a prepared food item, meaning that I cannot not offer for sale something as simple as a peanut butter and jelly sandwich. By supporting House Bill 889 to raise the $25,000 annual sales cap for cottage food laws, you would be helping make Maryland a great place to start or grow a small business. Thank you for the opportunity to provide testimony today, and I look forward to answering any questions the committee has.
Thank you for doing business in our state. We really appreciate it. Did you bring any bread for us?
Post-pandemic, absolutely.
Just kidding, just kidding. We have Mr. Kenneth Welch. Good afternoon.
Good afternoon, Madam Chair. Good
Good
afternoon,
afternoon.
distinguished members of the committee. My name is Kenny Welch. I'm the current president with the Maryland Conference of Environmental Health Directors. The conference represents the local environmental health
Actually,
programs.
sir, hold on a second. I made a mistake. Yours is an unfavorable report. So let me just take the favorable first. I apologize. We'll get to you, I promise, okay?
Thank
Are
you,
there
Madam
any
Chair.
questions for Delegate Chen or for Mr. Giancola? We have Delegate Bandari followed by Delegate Johnson. Delegate
Thank
Bandari.
you. Yeah, thank you, Madam Chair. Thank you, Delegate Chang. This is a great bill. I really like the idea. And it seems to me that just clarify, I think it allows CFBS the opportunity to expand and ultimately become the commercial licensed food retailer and do good business down the road, right? There will be that opportunity as well.
Yeah, there is currently the opportunity that's available if they can sell to the retail market, and there's an additional layer of oversight from the Maryland Department of Health. They would enroll, they would take a food server course or food safety course, and if they pass that, then they're able to go through the retail market. But what we're looking at with this bill is specifically to focus on the annual revenues, the sales revenues from the cottage food products to go from 25,000 to 100,000. And it's really a way to help stimulate the local economy. As I mentioned, Tom, the gentleman who is presenting today, he's right down the street here, sells his product at the farmer's market. It's just him and his wife, they're doing this right now on the weekends. His day job is he works for the federal government, and on Fridays and Saturdays and Sundays, he's doing this service. And within a few months, he was able to actually come close to that, exceeding the threshold.
Thank you.
Thank you. Next, we have Delegate Johnson, followed by Delegate Krebs.
Thank you, Madam Chair, and thank you, panel, for bringing this bill. Delegate, when we upped it to 25,000 and required a label, the Department of Health was one of the witnesses, and the question was asked if they had had any issues with cottage food businesses in the past, and they said no. So do you know by any chance, since it's been raised in the last year, have there been any issues with the cottage food business and the health department?
Thank you, Delegate Johnson, for that information regarding that. I don't know of any incidents particular. but we have a gentleman who's going to be representing the Health Officers Association. I would probably ask that question to them, but again, these are non-hazardous type of products. They're jam, it's pastries, bread, cookies, things like that. And so these products, the risk as far as any type of health risk to these products is very minimal.
All right, thank you. Thank you, Madam
Yes.
Chair.
And thank you, Delegate Johnson. Also, again, as I mentioned that with the labeling on the bill, it does labeling on the products, that it does provide accountability and transparency where these products are coming from, if there's any issues that arise from these products, so where consumers or the Maryland Department of Health or the local health department can follow up with.
Thank you. Delegate Krebs, followed by Delegate Bagnall.
Thank you. I don't know if Tom or the sponsor of the bill can answer the question, but in here it talks about annual revenues. I'm assuming that's gross revenues. That's not your net. That does not include all of the ingredients or any upgrades to your kitchen or any overhead. So that's a gross number. That's not even what your take home is. Is that correct?
That's a good question, Delegate Krebs. It is the gross sales revenue. And the reason why that's what the amount is, because each individual cottage food business, they have different fixed and variable costs. With, and Mr. Giancola could provide, but his fixed cost as far as purchasing additional stoves or kitchenware, those may be different from myself, that I don't have any experience in the industry and profession. So I would have to buy everything. So that would affect my profits in the initial first year versus Mr. Giancola, who may have those equipment and those kitchenware that he would exceed where I am currently. So those profits, the basic math, it's revenues minus expenses. That's what your profits are. Your retained earnings get next year. So those are all different. But this focus specifically on the gross sales revenues from the cottage food products.
Thank you. I was trying to get to even direct costs like ingredients, or it's a gross number, but that's great. Thank you.
Yes.
Next, we have Delegate Saab. Delegate Saab.
Thank you, Madam Chairman. So, I mean, I think it's a great bill. Matter of fact, I don't even think we have the 25. So this is definitely something that I like. The only question is I have, and often we always disagree with the fiscal notes that sometimes we get from DLS. And I'm looking at the fiscal note here, and I don't know if you can touch on that, or if you've had a chance to look and see that it's going to require a part-time position into a full-time position. And I'm not sure why would we even need a position. Have you had a chance to talk to them, like why there isn't even any need? Because it's the same bit, it's the same label they're looking at. They're just selling, how does it correlate the sales to having a staff member?
Thank you to the gentleman, Delegate Saab, for the question. If you look at the fiscal note states approximately $57,000 for the first year. And then as the years go by, that fiscal note decreases. From my understanding of reading the fiscal note, that it would entail, as far as staff reviewing and taking a look at what the labels are, and as far as maybe the different amount of businesses that would actually be part of this program and part of this market. And I think that's a good thing. If you look at as far as these different cottage food businesses, however they're set up, whether it be an LLC or a different type of entity, it's opening up a market where additional revenues are coming into our economy, which means we have more of a tax base. Which means if these businesses are expanding, they can also employ more people in our local communities. And these are local jobs that are being developed right in our communities.
Thank you. We have Delegate Hill.
Thank you. Thank you very much. I think I'll direct the question to, well, Delegate Chang, maybe you can decide if one of the cottage people can answer, or if you're the best person. The Maryland Department of Health raises some issues about, basically as we quadruple the allowance, this runs some risk in terms of the health, and that at some point we're having a two-tier system where the so-called cottage food industries are able to work under a different set of regulations. than the regular retailer. So my question is, at what point, as a cottage food business owner, do you feel that you would be ready to transition through an incubator or directly into being a regular retailer, manufacturer, producer who has to subscribe to all the health laws that we exempt the cottage food industry from? Is it above 100,000? Is there a higher level? At what point are you no longer cottage?
Thank you very much, Delegate Hill. If I may answer from a policy standpoint, and I'll defer to the gentleman who's a cottage food business owner on the front lines.
Actually, we only allow one person to answer the question.
Then I will defer. Then I will defer the question over to the gentleman who's actually in the cottage food business. Then.
Thank you.
Thank you, Delegate. Delegate Hill, to answer your question, I think that from talking with other cottage food vendors that have been at markets with me and sell products similar to mine, different from mine, that $100,000 cap, if it were to be raised to that level, I think would provide all of the businesses in the cottage food space enough of a buffer space where they would really be able to explore the market, understand what the customers are looking for, and get the experience that they would need to make that next step confidently, to go from where the current sales cap is at $25,000 to potentially a brick and mortar establishment where the lease alone would more than consume that in a year, is just too big a step and too big a risk for most cottage food businesses. So the $100,000 seems like a very reasonable and appropriate sales limit that would help make sure that we aren't disadvantaging restaurants and retail establishments, while also making sure that cottage food businesses are still very well controlled by the foods that they can make, by the Department of Health, which have all been determined to be non-hazardous already.
Madam Chair, may I ask a brief follow-up?
Very brief.
What about transitioning through incubator? You don't have to go to brick and mortar.
Absolutely. So incubator kitchens are a wonderful thing. Unfortunately, there's a very limited number of them in the state of Maryland. They do not exist in all of the counties. And the way that the cottage food laws are currently written, in order to be considered a cottage food business, you must prepare your food in your residential kitchen. So the minute I step into an incubator kitchen, I've lost the ability to operate as a cottage food business. So even the investment into renting kitchen space and working out of an incubator kitchen becomes a rather large leap. And oftentimes those incubator kitchens don't have necessarily the specialized equipment that a cookie maker might need, or that a jam maker might look for, or myself as a bread maker might need to make sure that we can produce the best product possible for the community.
Thank you, Madam Chair. Thank you.
My pleasure. Thank you. Delegate Lewis.
Thank you, Madam Chair. Thanks, Delegate Chang, for this bill. I immediately thought about one of my neighbors who during the pandemic, like you, Mr. Giancola, started baking bread. He specializes in bagels and he's called Back Alley Bagels. Just a little plug for my neighbor's bagels. But anyway, just thinking about how people often start at a very small scale like that. And it would probably take a long time to build a business of any consequence. I'm wondering why there's a cap at all. I'm just a public health person. I don't understand this whole idea of caps when we're trying to stimulate small business. Could someone explain that to me, whoever is best?
If I may, from my understanding from the research I've seen is that there are several other jurisdictions, states, actually Washington, D.C. there is no cap on it. And I think to your point, the Delegate Lewis, that a lot of these businesses, for example, at the bakery, the bagel person, the business that's near you, and then Giancola, who's right down the street from us, these are entrepreneurs who are starting it in their own homes, and sometimes there's a lot of active barriers as far as getting in, and and getting in, having a brick and mortar shop. So for them to be able to have this as a side hustle, I mean, we're in the gig economy right now, and the gig economy is definitely taking on a lot newer technology, but just have some old school bakers and people who are making food for us in our communities. I think that it really does help them, that they have their passion, they have their dreams, and that those barriers are lifted up, and then they can start in their homes and also be able to, once they get to that point of really going big, that they can take that out into a greater marketplace.
Thank you, Delegate. I would be interested to understand why we need a cap at all. I would like to lift that, but I appreciate you and thank you, Madam Chair. Thanks.
Thank you. Are there any other questions for this panel? Seeing none, thank you so much. Next, we have Mr. Kenneth Welch. Good afternoon, sir, and thank you for your patience.
Good afternoon, Madam Chair. Thank you again. Kenny Welch, currently the president with the Conference of Environmental Health Directors. The conference represents the local environmental health programs who regulate the food service within the state of Maryland. While the conference appreciates the intent of the bill, we're worried about the public health significance with the increasing of this annual revenue. The original intent of cottage food business was to allow food entrepreneurs to sell an unregulated as a startup business. The law was later amended to allow cottage food businesses to sell in grocery stores or food co-ops. The only requirement for that was for food safety course and label submittal. Startup businesses for the cottage food businesses are not required to take a food safety course or submit letter approval for farmers markets, public events, and personal or email delivery. By allowing the annual sales to increase from 25,000 to 100,000, we are getting beyond the original startup intent, and by doing so, quadrupling the amount of risk for contamination and mishandling, which otherwise can be performed safely in a regulated business. The nonprofit organization who performs food allergy research and education, FAIR, estimates there are 32 million Americans living with the potential of life-threatening food allergies. The number one allergic reaction happens in the home. Current law does not require a cottage food business to place does require them to put allergens on the label. However, there is no oversight. This still does not prevent the potential for cross-contamination to occur within the home. By increasing annual sales, we are drastically increasing the amount permitted to be prepared in the home and thus increasing the risk of individuals potentially having anaphylactic reactions to food. We respectfully request the committee give House Bill 889 an unfavorable report. Thank you.
Thank you for your testimony. Are there any questions? Delegate Krebs.
Hi, Mr. Welch. Thank you. We've done this as a pilot. We've had this bill in for years, and we've taken baby steps. So do you guys have any data on what the results have been and how many? You said it's drastically quadrupling the risk. So what is the risk now? How many reports have we had in the state or per county, and what level of risk is that we're quadrupling?
So each county presents that to the Maryland Department of Health each year. So the Maryland Department of Health would have that information for you.
So you don't have that handy for us today to look at?
I do
That would be
not.
very helpful to know if it 0 times 0 is 0. Just be nice to know what it is, what that risk is. Thank you. It'd be nice. Can you get that for us, for this committee?
Absolutely.
Thank you.
Thank you. Delegate Lewis.
Thank you, Madam Chair. Thank you, Mr. Welch, for your testimony. I'm curious, because I do appreciate your concern about the public health and protecting people at risk of food allergies. It's a very real danger that affects people's lives. So thank you for raising that and reminding us. But I'm just wondering if a solution to that challenge isn't to reject this bill outright, but perhaps to strengthen the existing statute to require cottage food makers to provide a warning that cottage made food, this doesn't have peanuts, However, if you are sensitive, there's a risk that this product could have been cross-contaminated, and we advise you to make your decisions accordingly. Would that answer your concern?
If it was amended, the conference would be happy to look at it.
Great. Thank you so much,
Thank you.
Madam Chair.
Thank you. My pleasure. We have Delegate Hill.
Thank you, Madam Chair. So let me ask this question. You've heard suggestions of take the caps off altogether, additional labeling. What about the option of creating sort of a intermediate tier without a cap, where some inspection, but perhaps not as much as a retail, but some initial inspection will be required, and maybe a periodic affirmation or something? I don't want to overburden the inspectors, but is that at all a possibility?
It's a possibility. You have to remember that local health departments are underfunded and understaffed as it is. Right now, the state health department does review the food safety course and the label submittal for the grocery store and co-ops, cottage food businesses. But we'd be happy to look at that.
Thank you.
Thank you very much. Any other questions for this witness? Seeing none, thank you so much for being with us today. This concludes the bill hearing on House Bill 889. Members, we have 3 bills left: House Bill 934, House Bill 783, and House Bill 757. We're going to take a break now. It is 3:40. We're going to take a break for half an hour. So you have to be back in actually in half an hour, okay? Thank you so much. Stretch your arms, get something to drink. Please return at 4:10. Thank you. No, Eric, 1 minute.
He just sent a request that he thinks you're developing the amendment?
Yes. Mhm. Okay, good afternoon, everyone. We're back. It's 4:11, and we have 3 bills left: House Bill 934, House Bill 783, and House Bill 757. We're going to get started with House Bill 934. Delegate Bartlett, Public Health Chief, Medical Examiner, Autopsy Findings and Conclusions. Good afternoon, Delegate Bartlett, and thank you for your patience.
Thank you.
You can get started.
Thank you very much. Thank you, Madam Vice Chair Pena-Melnick. And thank you, Chair Pendergrass and members of the Health and Government Operations Committee. House Bill 934 is intended to fix an inconsistency in a section of the health article. When it comes to how a person dies, it is important to know the truth. It is important to the state, and it is important to a person in interest. Under the general provisions of the article, a person in interest, such as a family member, can request a correction as to the chief medical examiner's autopsy findings and conclusions. This includes the cause and manner of death in one section and excludes manner in another section. The chief medical examiner has the authority to deny the request, and the person in interest may appeal the denial to the secretary and be heard in an administrative hearing. Respectfully, family members want to know and deserve to know on appeal whether their family member's death was a suicide, natural death, accident, or homicide. Included in my testimony is a recent court opinion in which the judge mentions the inconsistency and discusses the testimony that was presented at the time of the bill hearing in 1992, when we changed the law to allow persons in interest the right to challenge the cause of death. Circled in yellow in that section, in that edition, the Office of the Attorney General noted the inconsistency and called for a need for correction. The goal of the 1992 bill was to give persons in interest answers, yet there was never the change as called for by the Office of the Attorney General. I recently learned that an unintended consequence because the law was never changed, and due to the inconsistent wording, family members may be precluded from learning on appeal the manner of death. With that said, House Bill 934 is intended to fix the inconsistency. I would appreciate a favorable vote. That concludes my testimony, and I yield the remainder of my time to Reverend Marguerite Morris.
Good afternoon, Reverend Morris. Welcome to the Health and Government Operations Committee. Will you please start with your testimony?
Thank you and good afternoon. My name is Reverend Marguerite Morris. I'm the founder for Kathy's Sake and reside in Odenton, Maryland. I'm the mother of Catherine Sarah Morris, for whom the organization is named. I have been in a multi-year legal battle with police and OCME. I'm here today because I support HB 934, which should be called Catherine's Law. I would like to first emphasize the cause of death is not the matter. The cause is scientific and the matter is evidentiary. Catherine died from charcoal grills lit in her car. She was a victim of marital fraud and worth $100,000 dead. Her death was ruled a suicide in less than 24 hours with no investigation. We do not dispute the cause of death being carbon monoxide toxicity. We dispute how it got into her system. Because there were more than 50 investigative inconsistencies, we appealed to the OCME to have the manner of death changed. They denied our requests. We then appealed timely to the Secretary of the State. There was no response for 5 years. As a pro se litigant by financial force, I put forth a writ of mandamus and tried other court avenues 3 times. The state argued for dismissal 3 separate times, stating my avenue for being heard was the administrative hearing. Each of the 3 times, my cases were dismissed. In 2020, after writing a letter to the governor's office, I was granted the hearing. Then to my shock, the state changed its position, presented a motion to have the hearing dismissed, now claiming the law did not apply to me having a hearing. In essence, the state of Maryland was attempting to commit judicial estoppel. Their motion came before a judge who determined that was not the intent of that law. In addition, there was a letter that alleges this change would open up the floodgates for appeals to have all suicide rulings changed to homicides. To me, that is not even a realistic analysis. In my case, I was asking for a ruling of undetermined to prompt a thorough investigation. Tim Cameron, a St. Mary's County sheriff, told me his officers were summoned to a home death scene where the victim had been shot. But the word suicide was raised at the scene. The force made the mistake of investigating it as a suicide when it was really a homicide. Retired Officer Vernon Gerber wrote the article, The 7 Major Mistakes in Suicide Investigations, when there's assumption of suicide before the investigation. During my hearing, experts in DNA, forensics, pathology, fraud, and law enforcement investigations testified to the need for the change in the matter of death. In my hearing, expert retired PG Sheriff Jim Davis testified that from the moment police arrived, they should have treated the scene like it was a homicide until it was determined to be otherwise. Catherine's death certificate was signed on May the 6th, 2012. She died May the 6th, 2012. Her death was ruled a suicide on May the 6th, 2012. So this bill should be named the Catherine's Law because it will allow her voice from the grave to help others not fall victim to this ambiguity in the law. This amendment will guarantee that all persons who have equal access will have equal access to the appeal process and allow a neutral authority to see all parts of the evidence and hear both sides of the story. In closing, in my hearing when questioned, the OCME interim director, Pamela Southall, was adamant about if the police did not say it, then they were pretty much not going to hear the citizens of our voices of Maryland people. Maryland cannot afford to have someone in the helm of the OCME without an open mind to hear families and consider all the facts. I thank you today and ask you to please vote favorably for HB 934 and that it be named Catherine's Law. Thank you so much for your time today, everyone.
And thank you for your testimony today. And the committee is very sorry for your loss. Thank you for your leadership on this bill. Next, we have Mitzi Bernard. Mitzi Bernard?
Mitzi won't be testifying today.
Okay, great. So then we have Mr. Patel.
Hi, my name's Kush Patel. I was the attorney that actually argued on behalf of the appellant at the motions hearing that led to the decision by Judge Sinrod, which Delegate Bartlett has forwarded to everyone. I wanted to come here and offer my testimony in support of this bill because honestly, it makes common sense to me. First of all, as the statute stands, every portion of the bill has cause of death and manner of death in tandem up until you get to paragraph D, subparagraph 2, subparagraph Roman numeral 2, which basically only allows for the appeal of cause of death. And Delegate Bartlett's already gone into the legislative part of it, the AG's part, and Judge Sinrod, in her opinion, has gone into in depth why it should change. I just want to give an example. Cause of death is knife in chest. That's what killed me. It's black and white. Manner of death is, how did that knife get there? Did I put it myself? Was it a suicide? Did somebody else put it in me? Was it a homicide, or was it an accident? And to me, it's the manner of death logically makes more sense. It's more evidence-based. It's more factual conclusions-based, which logically makes it more appealable than cause of death. And this bill is not overhauling the whole statute. All it's doing is fixing a problem that the Attorney General's office has already said there was a problem with this. And that's all this bill that is in front of this committee today does. It fixes that hole, which has already been recognized at different levels in government. Thank you.
Thank you for your testimony today, Mr. Patel. We really appreciate it. Next, we have Ms. Charlotte Morris. Good afternoon, Ms. Morris. Ms. Charlotte Morris.
I'm sorry. Can you hear me?
Yes, we could hear you clearly. Good afternoon.
Good afternoon. How are you doing?
I'm doing
I thank
well.
you. All right. So I'm here on a heartfelt testimony for my sister. I'm thankful for the opportunity to speak on House Bill 934 in an attempt to advocate for so many families who have had and will continue to have questions surrounding the deaths of their loved ones. I'm in support of this bill, and I'm hopeful it can be named after my deceased sister, Catherine Sarah Morris. Her untimely death and recorded manner of death has been a dismal cloud over our heads and in our hearts. We have placed our hopes in several judicial proceedings to change her cause of death from suicide to undetermined, so we can have much needed investigation of her death. The Maryland Public Information Act guarantees the public's right to information about government activities. During the small investigation surrounding Catherine's death, every venture to go forward and seek information from these agencies has been an uphill battle. A ruling of undetermined death would have greatly helped in our quest for answers to deaths surrounded by controversy and deceit. My sister was entwined in a fraudulent marriage, which resulted in a $100,000 insurance payout to a man I've never met who did not come to the funeral. To not be able to appeal to the office of the medical examiner about something as important as a death of a 22-year-old who was weeks away from graduating college, beginning a new chapter in her life, is beyond heartbreaking. My sister's death was declared a suicide within 24 hours of finding her body. The people who knew and loved Kathy have not been able to rest in good faith due to known discrepancies surrounding her demise. She, like so many others, are just bodies found at a scene of a crime or an unfortunate death sent to the medical examiner. To family members, these bodies have names, they have stories, and they deserve every due diligence equally provided across the board. The citizens of Maryland deserve more than a rush ruling that leaves us feeling powerless and perplexed, because we will always be haunted with the feeling and the knowledge that more could have been done. This is why we implore the amendment to the House Bill 934 in hopes that the families going forward will have a right fairly appeal to the manner of death pertaining to their loved ones. Thank you.
And the committee is really sorry for the loss of your sister, okay? Thank you for—
I appreciate that. Thank you.
So are there any questions for this panel? And there's some. We're going to start with Delegate Collison, followed by Delegate Johnson. Delegate Collison.
Thank you, Madam Chair.
My pleasure.
Thank Ms. Norris and Reverend Norris for their testimony and their story. Delegate Bartlett, I'm not sure that this was actually stated, and if it was, I apologize, but am I to assume from your testimony that if a death is ruled a suicide, there is no further investigation, it just stops right there?
Thank you, Delegate Cullison, for your question. If a death is ruled a suicide, the family does not have the ability to, may not have the ability to appeal. The chief examiner could make the change on, on his or her own, just make that correction on their own. But the appeal process is where we get stuck, because it's the manner that they want to, that the family members want to know. And if it's a suicide, then they may not get into the manner if that appeal is not granted, because that language is not necessarily in the bill.
So, but I'm understanding though, it's kind of like if the designation of suicide is made, as far as the chief examiner goes, it's done. There's no further, questioning of anyone. It's like, okay, this was a suicide. We don't have to do anything else.
It can be that situation.
Okay.
It can be that way, because the family members have 60 days to appeal. So two things can happen. One, they might miss that 60 days and they may not have that opportunity to appeal. In cases of a homicide, there is no appeal process. And sometimes what family members want to know is this a suicide or is this a homicide? And if it's indicated a suicide, then there has to be an actual request to the medical examiner to correct the findings. The medical examiner could deny that request. And therefore the family would not know, in fact, if it were actually a homicide and not a suicide. I hate to say it, but sometimes it's easier to rule it a suicide rather than a homicide.
That's what I'm understanding. Thank you, Delegate. Thank you, Madam.
My pleasure. Next, we have Delegate Johnson, followed by the Speaker Pro Tem.
Thank you, Madam Chair, and thank you, Delegate Bartlett, for bringing this bill. This is an important bill. Just for clarity, can you explain to the committee exactly who falls in the category of a person in interest? Is that just family members, or does it go beyond family members? If you could clear that up for us.
Sure, it actually goes beyond family members. And in the fiscal note, they did a great job of going a little bit farther on page 1, with the exception of cases where the finding is homicide. A person, it says of interest, and I also said of interest, but the law actually says a person in interest. It's defined as a spouse, an adult child, a parent, adult sibling, grandparent, or a guardian of the person of the deceased at the time of the deceased's death.
Thank you. Thank you, Madam Chairman.
My pleasure. We have Speaker Pro Tem Simple Hughes, followed by Delegate Bagnall.
Thank you, Madam Chairman. And thank you, Delegate Bartlett, for this bill. You really raised the area of just not knowing that this is something that is occurring. And so you certainly opened our eyes to this, and I certainly extend my sympathy to the families. I wanted to reference the letter from the Department of Health with regards to the cost, $19,000 per case. Does the family, if they were to appeal, is that where they would have to incur any of that expense as well? Because I believe it's my understanding right now, if the person is deemed to have to go to the medical examiner, not given, let me back up. If the family requests it, then they have to incur the cost. If they don't, then the state incurs it. Are you aware of what that would be for this particular situation as well?
Madam Speaker Pro Tem, I'll do my best to answer that question. However, unfortunately, the family of Reverend Marguerite Morris is, unfortunately, as she mentioned in her testimony, she's become quite the expert on this matter. And she brought this error to my attention. From what I have done, from what I have come to understand based on my research, yes, I believe the family definitely pays for the hearing, for the administrative hearing. I don't know if the family, and from reading the testimony that was provided for information, I do not believe that the family actually pays for the the reexamination or the, the examination itself. And I think that's where they're getting that figure from. That's my understanding. And Reverend Marguerite Morris could correct me if I have anything wrong on that.
We only allow one witness.
Oh, that's right.
In this committee to answer the question.
Yes, well, that's my understanding, Madam Speaker Pro Tem. And I think that when the, if the letter of information is addressed by the next panel, perhaps they would have a better answer.
Okay, thank you so much.
Thank you.
Thank you,
Delegate
Vice
Bagno.
Thank you, Madam Chair, and thank you to the sponsor for bringing this bill. I wanted to circle back to the letter from the department as well, because it seems to be in some conflict with the fiscal note. And I'm wondering if you know, does a determination that it is not a suicide automatically open up an investigation for homicide? Because from the testimony from Reverend Morris, it sounded like they were looking for an undetermined. So if that's not automatically triggering an investigation, if there is a change in that determination, you know that whether or not that would automatically trigger a reinvestigation.
May we let Delegate Reverend Morris address this question? Okay, Reverend Morris.
Yes, thank you.
We can hear you very well.
Okay, is that better?
Yes, if you can come a little closer, that would be wonderful.
Okay. Is that better?
Yes, it is. Thank you.
Yes. I think that, be all honest with you all, I think the letter is a little misleading, because I don't believe that 500 people, the suicides, are going to all of a sudden, appeal it. Because the appeal is to have a neutral party hear both sides of the story. And you don't go from suicide to homicide without a reinvestigation. So it's very probable that some people may appeal it. It may get it undetermined, or it may get the police have to come back in and reinvestigate. So there's not an immediate cost. It's not because you appeal it goes to be a homicide. We have not used the words homicide with Catherine, even though we believe she was harmed. We're asking, like so many other families, I'm sure, to get a thorough investigation, because they still have questions around the death and perhaps the death investigation itself. So that's the appeal process. And my family has carried the burden of this financially. But what I must say is that one of the deterrents already is the cost of things. So you're not going to have a whole lot of people appealing this, because they will not be able to handle the cost. Just from the personal family point of view, to retain a lawyer and all of that, it's so that bill, that amount that's in the letter, I think is greatly exaggerated, and the probability of that happening is null and void, because they also don't talk about how many people actually tried to appeal suicides. They said it's contested or appealable, but the numbers don't match the letter. Thank you.
Thank you. Thank you, Madam Chair.
My pleasure. Are there any other questions for these witnesses? Seeing none, thank you so much for your testimony today. And again, we're sorry for your loss. We really appreciate your testimony, and have a great day, okay? This concludes the bill hearing on House Bill 934. Next, we have House Bill 783. And with us, we have from the Ways and Means Committee, our wonderful colleagues, Delegates Branch, Delegate Shoemaker, and Delegate Guyton. Good afternoon. And if you have any questions, please let me know after the witnesses testify. And this is Delegate Queen. And the title is Work Group on Screening Related to Adverse Childhood Experiences. Good afternoon, Delegate Queen. Welcome to the Health and Government Operations Committee.
Good afternoon. Well, good evening. Thank you all, Madam Chair and members of the Health and Operations Committee. And if you have any Ways and Means Committee members still there, I welcome you as well. Thank you for the opportunity to hear this bill. You actually heard it last session, and we were advised to look into a work group. And so for many people, that sounds like the death of a bill, but in this case, I think it's very important to look at this from a work group standpoint. So that's why we're back this year with this bill. And so I want to talk about why this bill is needed. You've heard a lot today about trauma that has happened in communities, happened in families. And so what this bill does, Adverse Childhood Experiences, this work group screening, is looking to move beyond what some of the prior bills have done in looking at diagnosis and treatment, but to look at at early detection and prevention, because trauma is going to happen in the lifetime of an individual. And so what we want to do is try to build more resilient youth and more resilient communities and adults. And so the approach is to what we've done. I've worked with Senator Augustine, who has convened over the interim many health professionals, many groups to talk about how we can achieve this. And so we basically are looking at a model that's done in California, and it's really been very successful. I'll put the link in the chat box of what California has done to build basically healthy families and from the beginning, what they call it. And so what this does is have the work group will look at what would be appropriate screening tools, what would be appropriate resources available, so as families encounter adverse experiences, they have the appropriate treatment to take care of that. And so I'm going to let you hear from some of the other professionals, but this is really just getting to the heart of issues that we've seen. You've talked about it here. If you experience suicide, if you experience homelessness, if you experience family divorce, if you experience substance abuse or child abuse, how those issues impact you as an adult, and what can we do to try to mitigate those impacts to your health, to your propensity to engage in substance abuse or repeat some of those things you saw before. And so we hope to get a favorable recommendation on having this work group. And I think we have a great model in California that we can use to show how we can work together to get this done.
Thank you, Delegate, and we'll give your time left to your experts. We have Mr. Jeffrey Edwards. Good afternoon.
Good afternoon. Thank you, Madam Chair and members of the Health and Government Operations Committee. My name is Jeffrey Edwards, and I urge a favorable report on House Bill 783 regarding the creation of a work group on ACEs, or Adverse Childhood Experiences. As a medical student at Stanford University School of Medicine and a Master of Public Health candidate at Johns Hopkins Bloomberg School of Public Health, I have experience and knowledge in these fields that informs my support of this bill. In particular, I've worked with Delegate Queen and Senator Malcolm Augustine in their offices in establishing a relationship with Dr. Nadine Burke-Harris and the Office of the California Surgeon General, which was created to implement their innovative ACEs Aware initiative. For more background, ACEs are these experiences which require significant adaptation by the developing child in terms of psychological, social, and neurodevelopmental systems, and which are outside of the normal expected environment. CDC reports nationally that nearly two-thirds of children have experienced one ACE, and over 1/5 of children have experienced more than 2 ACEs during childhood, which can then lead to a toxic stress response due to the excessive activation of our normal stress response system. The toxic stress leads to disruption of our body's normal processes, both physical and mental, leading to a higher risk of poor health outcomes over time. Some of these health effects happen as early as infancy, with high adversity in infancy associated with growth delays, sleep disruption, developmental delay. And we see these issues continue to happen throughout the lifespan, also increasing risk of mental health disorders, substance use, and as well as chronic diseases such as diabetes, cancer, and heart disease in adults. So by screening for youth for ACEs early and regularly, pediatric care providers and their behavioral health care partners can implement primary prevention strategies to educate caregivers about the impact of these adversity on the child's developing brain. And so House Bill 783 would establish a work group to evaluate the evidence surrounding ACE screening in medical practices, which allows us to identify the most effective methods of protecting our children from unmitigated ACEs. We can learn from California Surgeon General and make a better Maryland for all children. Thank you for your time and consideration, and I urge a strongly favorable report on House Bill 783.
Excellent time. Thank you very much. Next we have, actually this is favorable, that it ends there. We have a favorable with amendment next. So are there any questions for these two witnesses? Okay, Delegate Hill.
Thank you, Madam Chair, and thank you, Delegate Queen, for bringing this really important bill and improving it over last year. There were, you're going to hear in the following panel, but I wanted you to have a chance. There are a couple of amendments that are recommended. One is to add someone from the domestic violence center of background, and one is to change one of the reports to task them with identifying resources in the community that that pediatricians and family practitioners can use in directing care of their patients. And then there's another one. Are you familiar with it? Do you have any objections as I've described those amendments to you?
No, I don't have any objections. I had heard of a couple of those, so I don't think there's any concern with
Very good.
those,
Thank you.
those amendments. Sorry.
Any other questions? Seeing none. Oh, yes, Delegate Lewis.
Thank you, Madam Chair. And thank you, Delegate Queen, for bringing this bill. There are a couple of bills moving or percolating around that address adverse childhood experiences, or ACEs. And I know this is a topic that's really important to you, and I thank you for your work on it. I was just wondering how this bill might add or synergize with some of the other ACEs bills, or if you think a work group is the place where we should start.
I think the work group is a good place to start. As I alluded to in my testimony, that the focus of this bill is to move to the early detection and prevention part of it. I know a lot of the bills we have now have dealt with, you know, how do we diagnose and how do we treat, which are very important. We still, and the work group can help to help us with, you know, fine tuning that. But I want us to make sure that we are definitely moving towards this early detection and prevention process. And so looking at the model that California has, which is really getting to the root cause of some of these things and addressing these issues before we see them manifest in adults, which is really the big cost impact to us. And so that's how this bill is slightly different, but the work group can help to fine tune those other bills, I believe.
Great, thank you, Madam.
Sure.
Any other questions? Thank you. Seeing none, we're going to move now to the panel with favorable with amendment. We have Ms. Melanie Shapiro. Ms. Shapiro, good afternoon.
Good afternoon, Madam Chair, members of the committee. Melanie Shapiro with the Maryland Network Against Domestic Violence. We are the federally recognized state domestic violence coalition. I'd like to thank Delegate Queen for bringing this very important bill. And before I share my prepared remarks, would like to respond to Delegate Lewis's very appropriate question regarding sort of the impacts of these different bills. The early identification and screening is what this bill would address. There was another bill, the trauma-informed care bill, which is more about the response once the ACEs have been identified. And so both of them are critical because we need to both have early identification and provide services. The wonderful news is that kids are incredibly resilient. And so when ACEs are identified and services are provided, we can hopefully avoid the identified impact of the adverse childhood experiences. And that needs to be done also in a trauma-informed way, which was another bill that this committee, I believe, heard. And the reason why the Maryland Network Against Domestic Violence will support this bill and would like to be part of the effort is because witnessing the physical violence against your mother is one of the original adverse childhood experiences. It was endorsed in the original CDC Kaiser Permanente study by 12.7% of the people who were surveyed as having been exposed to domestic violence. And what's incredibly upsetting to learn is that it often doesn't occur alone. It normally co-occurs with other adverse childhood experiences, most notably child abuse. We'd like to avoid these from happening, obviously, because nobody wants the children to be experiencing these adverse childhood experiences, but also because the exposure and experience of any ACE is actually an indicator for being a future victim or perpetrator of domestic violence. So we think that this early identification and screening and then intervention would have a tremendous impact and positive impact on our children in Maryland. So for all those reasons, we urge a favorable report with amendment on this bill.
Excellent timing. Thank you for your testimony. We really appreciate it. Are there any questions for this witness? Seeing none, thank you so much for giving us your testimony today. And thank you to the Ways and Means Committee for being with us. This concludes the bill hearing on House Bill 783. Thank you very much. Next, we have the last bill of the day, our wonderful colleague, Delegate Bagnall, House Bill 757, Local Health Departments and Community Action Agencies, Feminine Hygiene Products. Good afternoon, Delegate. Will you be so kind and get started?
Good afternoon, Chair, Vice Chair, and members of the committee. For the record, I'm Delegate Heather Bagnall, District 33, Anne Arundel County, and I'm here testifying on behalf of HB 757, Local Health Departments and Community Action Agencies, Feminine Hygiene Products. You have my written testimony, so I will summarize. Menstrual health is an equity issue. According to the Period Project, each year people in the United States spend more than $2 billion on menstrual hygiene products. We have taken a great deal of strides in Maryland to ensure greater equity when it comes to menstrual health, eliminating the luxury tax, requiring access to menstrual products for our incarcerated communities and our homeless shelters, requiring schools supply no-cost menstrual products to students. This year, we have additional legislation regarding access for our adolescent populations, as well as tax incentives for donations. But we have no state or federal mechanism to ensure delivery of menstrual products for our low-income and most underserved populations. Federal programs such as WIC and SNAP do have extensions for essential medication, but not for menstrual products. Health savings programs allow for a deduction for menstrual products, but are only available through private insurers. According to a research report in obstetrics and gynecology, more than 1 in 5 women in a major US city couldn't afford menstrual hygiene products. Poor menstrual hygiene can cause serious health risks, such as urinary tract infections, reproductive tract infections, and for infertility, and is a major contributing factor to the development of cervical cancer. HB 757 seeks to address this gap community of low-income people by working with the local health departments and community action agencies who already have a strong foothold in those communities to provide no-cost menstrual health products. It was brought to me by Sarah Khan, who is working with Seventh Generation, and it's modeled on federal legislation. HB 757 would establish the framework to address this community and work within the federal bill, which provides funding. However, as this bill has not yet passed in Congress, we are looking at strategies to amend the bill so as not to establish and pass an unfunded mandate. I have spoken with Ruth Mariana from the Maryland Association of County Health Officers, as well as Devian Percy from Maryland Community Action Partnership, who represent all 17 community action agencies. And they're in support of the intent, but also want to ensure we aren't creating overly financially burdensome legislation, as they too recognize this significant need. MCAP is considering amendments to offer as much of their budget is restricted, and this bill as drafted would have little to tremendous impact on individual agencies depending on the margins of their budgets. You will see there is broad scale support for the need and the intent of this bill. I will be offering amendments to the subcommittee and look forward to the opportunity to continue to work for the most effective and impactful mechanism to address the needs of our most vulnerable populations and address this very real equity, health, and dignity issue. Thank you very much for the opportunities to present this bill, and I ask for a favorable report.
Thank you, Delegate, for this bill. We appreciate it. We have next Ms. Kang. Good afternoon, Ms. Khan.
Hi, Good afternoon, everyone. I hope you guys are all having an amazing day. Thank you for having me. It is an honor to be speaking today. My name is Sarah Khan, and I'm 13 years old. I'm actually the one who started this bill. I've been very passionate about the issue of lack of accessibility to menstrual products and have done various drives for different local organizations. However, while these drives did help many, there are still so many women out there who are struggling to obtain products. This bill will make menstrual products available to even more women. So as to whether this bill passes, I don't see a reason why it shouldn't. Yes, it will take money and time, but isn't that something that we owe to the women of our community? We don't choose to have periods, so why should women be burdened unnecessarily with the outrageous cost of period supplies? 1 in every 4 women do not have adequate access to these absolutely vital products, and for those women, buying menstrual supplies can take a large chunk out of a small paycheck. I woke up this morning with my period, and I'm not afraid to say that because periods have been seen as a taboo topic for far too long, and it is unacceptable. We should be helping these women in need, not ignoring them and hiding the fact that periods do exist and need to be properly taken care of. I realized how lucky I am to be able to simply grab a pad and continue on with my day. But on the other hand, 20% of women are not able to attend school or work because they cannot afford menstrual products, and during their period it is difficult to go places without supplies. Some even have to use other unhygienic items such as socks, which can lead to various health issues. Having a period is a fact of life for all females, and sanitary products for this purpose are not much less essential than food, and I don't stand alone on that. 88% of women agree that period supplies should be considered essential. The encumber of accessing and paying for menstrual products is significantly affecting lower income women, and that should not be the case. Even items such as condoms are provided in some cases, so it is completely absurd that menstrual products are not, because they are essential for all women, and that is a fact. Thank you.
Your time was excellent, and thank you for being a leader. It's very impressive. Next, we have Ms. Kimberly Haven. Ms. Haven, good afternoon, and will you be so kind and give us your testimony?
Yes, good afternoon. Thank you so much. My name is Kimberly Haven, and for the record, I am the Director of Reproductive Justice inside. Last year, we have started building on these campaigns with trying to get menstrual hygiene products within schools, as members of the General Assembly know. We also had a bill that passed that provided menstrual hygiene products for incarcerated individuals. This is just another example of where we need to be moving forward. At the end of the day, more and more women are facing period poverty, largely due to the pandemic. And as the young lady spoke before me, girls will not go to school, women will not go to work. This is just strong legislation that goes to the heart of gender equity. And there is precedent for this. Other states are looking at it, but an entire country just did this. Scotland did this. They recognized the need for these products to be made freely available, and their vote was unanimous. No one should have to worry about whether their next tampon pad or reusable product is coming from. This is at the heart an issue that is important to all women and all girls. This is good policy. This is something that we can do. We could be a leader, much like Scotland. And for these reasons, I urge this committee's favorable report of HB 757. Thank you so very much.
Thank you, Ms. Haven, for the work you do. At this point, I'm going to ask my colleagues if they have any questions of you. Are there any questions for this panel? Seeing none, thank you so much for being with us today. We really appreciate your testimony. And Ms. Khan, very impressive. You have a blessed day as well. And colleagues, this concludes the bill hearings. And it concludes the bill hearing on 757, and it concludes the bill hearings for the day. I hope you have a great evening. Thank you so much.